Welcome back. Transitions of care present important challenges and opportunities for improving diabetes care. It's a period of high risk for medication errors and miscommunication, which can lead to harm. Last month, the Commission released the Medication Management and Transitions of Care Stewardship Framework to support safe and high quality medication management at the transitions of care. You'll hear the key elements of this framework highlighted throughout the next few presentations. To start the session, Associate Professor Spiros Falanos is here to tell us about the management of diabetes medicines during and after hospitalisation.
My name is Spiros Falanos. I'm the Director of the Royal Melbourne Hospital Department of Diabetes Endocrinology. I'm very grateful to the organisers of the National Medicine Symposium 2025 for the opportunity to present on transitions in diabetes care, specifically when it comes to the hospital journey with diabetes. So the outline for this presentation is fairly straightforward. We'll be discussing medication use prior to hospitalisation, medication use during hospitalisation, and diabetes medication use after hospital. And of course, this is very relevant to the NSQHS standards. Things such as preventing infection and partnering with consumers. When it comes to diabetes in the inpatient setting, unfortunately the reality is that approximately 1 in 4 people admitted to hospital have diabetes, and it's been well documented in multiple Australian studies over the last decade or so, including the recent Queensland inpatient diabetes study, which surveyed the whole state and established 24% of people have diabetes. So the reality is that acute illness and surgery alters physiology, and diabetes often becomes less stable when people are in hospital, characterised by great glycemic variability and periods of marked hyper and hypoglycemia potential, and therefore diabetes medications need to be monitored from this transition before hospital to in hospital and then after hospital. When it comes to the pre-hospitalisation themes, the areas I'll cover are medication complexity, which I gather has already been touched upon the sessions as part of this National Medication Symposium on Diabetes, the medication assessment prior to elective surgery, with a specific focus on the GLP-1 receptor agonists and the SGLT inhibitors. So you'll be aware of the many diabetes medication classes which are spawning, and the reality is that the pathophysiology of diabetes is complex, and fortunately we have emerging drug classes which are dealing with all these different pathophysiologies, and therefore the medication regimens these days are far more complex than they used to be. You'll also be aware that national and international guidelines are strongly advocating consideration use of the GLP-1 receptor agonists and SGLT inhibitors, given their great level 1 evidence base for cardiac and renal protection, and therefore people with established atherosclerotic cardiovascular disease or heart failure or CKD being recommended to consider these medications very early, often second line after metformin. We're also aware that the GLP-1 receptor agonists and the SGLT inhibitors can promote weight loss, and they can be very effective at combating the issue of abdominal obesity. We at the Royal Melbourne Hospital have published on the DINGO study, which highlights that one's in-hospital hyperglycemia status is independently associated with adverse outcomes, including healthcare-associated infection, acute kidney injury, and stroke. And therefore, it's important we focus on improving diabetes care in the hospital, not to mention adverse patient experience. We have Professor Jerry Raymond from the United Kingdom to thank. He's done a marvellous job of establishing the National Diabetes Inpatient Audit across England and Scotland and Wales. And Jerry and his colleagues in the UK established that hypoglycemia is extremely common, affecting 1 in 12 inpatients, diabetic ketoacidosis occurring in hospital in approximately 1 in 25 people with type 1 diabetes, not to mention the development of foot wounds and multiple medication errors. And I can tell you that these data are very similar to what we're observing in Australia. The professional societies, in particular ANZCA, AGISA, and the Australian Diabetes Society, as well as the National Association of Obesity Society, have come up with recommendations for the GLP-1 receptor agonists as there's been great confusion. And now the conclusion, based on not only Australian guidelines but also British guidelines, is that these medications do not need to be paused actually before surgery unless there's a major concern regarding gastric emptying. And that's because the half-life of these medications is really very long, in the order of 5 to 7 days. Therefore, one would need to pause these medications for a month for the drug to fully wear out the system. And the reality is it's best that these medications are continued as the risks of perioperative issues are low. It's also important to consider with this particular guideline, there's a recommendation that clear fluid diet be adopted in the 24 hours prior to surgery before patients embark on a 6-hour fast before their procedure. And this may necessitate adjustment of medications. For example, sulfonylureas may need to be withheld during this clear fluid period, as well as insulin dosages decreased. When it comes to the SGLT inhibitors, the guidelines for these are more well established and been published over 5 years ago. And we recommend that the SGLT inhibitors are withheld for 3 days, 2 days prior to surgery and the day of surgery, to minimize the theoretical risk of developing diabetic or euglycemic ketoacidosis. So what about in hospital? Medication changes need to be made for safety, to improve glycemia and certainly combat the tendency to dysglycemia, as we discussed. Also, early intervention multidisciplinary care is shaping up as being extremely important, and medical device technology is changing the way we approach diabetes in the hospital. When it comes to the fundamentals of inpatient diabetes care, these days for significant acute illness and longer hospital stay, we favour the use of basal bolus insulin therapy. Usual diabetes medications are paused, such as sulfonylureas and premixed insulins, given the risk of hypoglycemia, and SGLT inhibitors due to the risk of ketoacidosis, and rarely lactic acidosis metformin, and we transition people to multi-dose insulin. We typically base this off a calculation at 0.5 unit per kilo, giving half as basal insulin and half as rapid-acting insulin divided into TDS dosages, assuming people are eating. There are special considerations which need to be taken into account, which is previous insulin requirements, weight, also renal function, which can lead to a dose reduction of insulin, and adjunctive therapies such as DPP-4 inhibitors and GLP-1 receptor agonists. We have demonstrated through our 2 large trials, the RAPIDS trial and the STOIC-D surgery trial, that early multidisciplinary specialist diabetes care improves outcomes. So multidisciplinary teams are used to provide care, especially for more complex cases of diabetes involving endocrinologists, nurse practitioners, diabetes educators, dietitians, and pharmacists. And we've shown to improve outcomes not only for glycemia, but also reducing infection. And clearly, electronic tools such as electronic medical records and network glucose meters are paramount for providing better care. So the reality is continuous glucose monitoring is starting to increase in use, especially in people with type 1 diabetes, and Australian data are depicting this. And the reality is we're poised on a transformation which will come upon inpatient care, whereby CGM will be used more liberally for many people with diabetes to avoid hypoglycemia. And even automated insulin delivery pump systems in future will be used. So really it's a very exciting time for us in diabetes care. Even in the hospital we can use these technologies. When it comes to the transition to home, it's important that medication changes are communicated back to the primary care teams, because there are multiple changes occurring, and early intervention in hospital can hopefully benefit ongoing primary care efforts. The discharge planning considerations involve the pre-existing glycemic status. If one's HbA1c is typically reasonable, for example under 7.5%, we may typically recommence people on their usual treatment regimen. Of course, we need to discuss this with people with diabetes, the inpatients, understand their preferences and safety factors, and also their cardio, kidney, metabolic health, and ensure that these management plans are communicated back to primary care. I realise that's not often done well. It's important this information is conveyed in discharge summaries and separate letters. And then a plan for medication adjustment, whether people will continue on insulin, whether they'll be weaned off insulin, and then the follow-up needs to be very well defined. Most people can be managed in primary care with diabetes. Sometimes we deem that specialist short-term care is required, and for the very complex cases, let's say complex type 1 diabetes, then we may require long-term specialist care. And you'll be aware of all the various medication classes. and their pros and their cons and their potential benefits for cardiovascular protection, renal protection, even liver protection, and risk of hypoglycemia impacts on weight. And therefore, we need to individualise the decision making. And I can tell you that we have RCT data based on our studies, the RAPID study and STOIC-D surgery study, to show that if you intervene earlier in hospital with specialist diabetes care, the glycemic benefits are translated even beyond discharge, with reductions in A1C of between 0.5 to 1.2% over the ensuing 12 months. So to summarise, the transition in care is really very significant with hospitalisation. Pre-hospitalisation is important to assess for safe usage of diabetes medications, including a plan for the GLP-1 receptor agonist, which ideally should be continued, and pausing the SGLT inhibitors, and optimising glycemia. If somebody has an A1C of above 9%, then perhaps their diabetes should be optimised before they have their elective surgery. During hospitalisation, medications often need to be paused, and people need to be treated with at least basal and most likely bolus insulin. And we recommend early multidisciplinary care for those more complex cases with diabetes. And then prior to hospitalisation, these plans for the medications need to be communicated clearly back to the primary care team, who then have a range of different medication options to improve the long-term outcomes of people with diabetes. So thank you for listening to this presentation. I'm very grateful to Dr. Georgina Mouse, our registrar, who assisted me with preparing these slides, and thank you very much.
Thank you, Spiros. How does the management of diabetes differ during pregnancy in women with pre-existing diabetes and gestational diabetes? Here's Associate Professor Glynis Ross.
I'm Associate Professor Glynis Ross, and I'm the lead endocrinologist at the Royal Prince Alfred Hospital Diabetes in Pregnancy Service in Sydney. And it's a pleasure to present to you today on aspects of diabetes management during pregnancy. I have no disclosures relevant to this presentation. So during this presentation, I will outline the impact of diabetes on pregnancy and discuss some specific aspects that are both different and similar between pre-existing diabetes and gestational diabetes. So why is diabetes in pregnancy a concern? So for a mother with pre-existing diabetes, there's increased risk of miscarriage and either development of new or worsening existing diabetes complications. For all women with any form of diabetes in pregnancy, there are higher rates of hypertensive disorders and of caesarean delivery. Specifically for women with gestational diabetes, they are at risk of future diabetes and of future cardiovascular disease. From the infant's perspective, the infants of mothers with pre-existing diabetes, there's high rate of congenital anomalies and of stillbirth or perinatal death. And for the infants of all diabetes in pregnancy, there is more likelihood of macrosomia or large for gestational age, neonatal hypoglycemia, need for neonatal unit admission, risk for future metabolic syndrome, higher rates of autism, and indeed that is graded so that it's highest risk for those of mums with type 1 diabetes than for those of mums with gestational diabetes, and also of fatty liver. So these are some Australian data which show that for pregnancies complicated by pre-existing diabetes, the rate of congenital anomalies, hypertension in pregnancy and stillbirths are about 3 to 4 times higher than for pregnancies where there is no diabetes. And the anomalies, if we focus on that, are across all systems. And as you can see in the bottom right-hand corner here, where it's just demonstrating the major cardiac defects, as the HbA1c in early pregnancy rises, there is a substantial increase in the risk for congenital anomalies. So tight, optimal glycemic control leading into pregnancy and in early pregnancy where critical organ formation is occurring. So with pregnancies in Australia, there are around 300,000 births per year and 48,000 will be associated with diabetes. Only around 3,000 are in women with pre-existing diabetes, giving a rate of around 1 in 100 pregnancies. And these are split mainly between type 1 and type 2 diabetes, and the proportional split does vary according to the local population. Around 45,000 pregnancies per year are complicated by gestational diabetes in Australia, giving a rate of around 1 in 6 to 1 in 7 pregnancies. And the subcategorisation of this will be the terminology used with the new diagnostic criteria. So in a pre-pregnancy setting, if we look at the specific issues that relate to women with pre-existing diabetes, it is really important that they be referred for diabetes-specific pre-pregnancy counselling. They should be encouraged to be using reliable contraception until they're in an optimal setting from the medical point of view, not just when it's in the optimal setting from life issues, which clearly is an important consideration as well for the women. They need optimal glycemic control and trying to have their glucose levels at target leading into the pregnancy. From the diabetes medication perspective, insulin and metformin are safe in this setting, but all other diabetes medications should be ceased. Of particular note with the GLP-1 agonists, the recommendation at present is that they should be ceased 2 months before starting to try for pregnancy, and there have also been some concerns that use of the GLP-1 agonists may be impacting on the reliability of oral contraception, and this is another factor that will need to be taken into account in these women in the pre-pregnancy planning phase. A lot of women with pre-existing diabetes may be also on other medications that need specific consideration. In particular, these may include antihypertensive medications, and with these, there should be a review of these medications and ensured that they are on pregnancy-safe choices. Women with pre-existing diabetes should be advised to take high-dose folic acid starting at least 2 to 3 months ahead of trying for pregnancy. And the standard recommendation has been 5 milligrams a day, but now the recommendation is to not exceed 5 milligrams per day because of some concerns that the higher doses may again be associated with some increased risk of autism. So if women are taking another pregnancy supplement, particularly to get iodine, as is recommended in Australia, the recommendation with a high-dose folic acid is to just take half a tablet of it per day so that they are not going to exceed 5 milligrams in total. These women will also need diabetes complications assessment, particularly looking at their eye status and kidneys to make sure that they optimal in a pre-pregnancy setting. So depending on the individual assessment of risk, there may need to be a baseline measurement of an HbA1c with a fasting glucose level or consideration to proceed as well to a glucose tolerance test. As for all women planning pregnancy, they should be counselled to have low-dose folic acid unless there's some other indication for a high dose. As you may know, diagnostic criteria for gestational diabetes have recently changed. There have been multiple variations of the diagnostic criteria and testing recommendations over the last 40 plus years, and they are summarised here. Recently, there has been a publication in the Medical Journal of Australia with Ariane Sweeting as lead author of the new Australasian Diabetes in Pregnancy Society recommendations for GDM screening and the diagnostic pathway. To summarise the points, if women have risk factors for gestational diabetes and they are specified in the document, it is advised that they be assessed early in pregnancy, but if early testing is normal, they should be advised to have a GTT at the routine time of around 28 weeks, which is the same time that women without risk factors for gestational diabetes are advised to be tested. There also is still a need for glucose tolerance testing or other glycemic status assessment if there are clinical concerns at any stage of the pregnancy. And in particular with the oral glucose tolerance testing, the criteria for cutoffs are going to be slightly higher than we've had in recent times, using the HARPO 2.0 odds ratio rather than the 1.75. But please note that whenever women have been diagnosed in the past with gestational diabetes using any of these criteria, they will still be at higher risk of future diabetes than women who have never been diagnosed with GDM in a pregnancy. Now, during pregnancy, for women with pre-existing diabetes, particularly those with type 1 diabetes, it should be managed in a specialist diabetes and pregnancy service. There is not going to be a lot of experience managing these women in minor centres. They need to be managed with optimal glycemic control throughout the pregnancy with very frequent contact and management review. The medications will be potentially considering metformin in the setting of type 2 diabetes. Most of these women will also require a multiple daily insulin regimen, and the specific regimen needs to be tailored to their glucose pattern and needs. For women with type 1 diabetes, they also may be on a multiple daily insulin regimen, but an increasing number are coming through now on insulin pump therapy. And again, the settings need regular review and adjustment. There is particularly an increase in insulin requirement seen after 24 weeks, and peak requirement is usually sitting around 34 to 36 weeks. For some women with type 2 diabetes who have significant insulin resistance, they may be requiring more than 500 units of insulin per day, which is quite challenging to deliver, and they may need concentrated insulins to be able to provide this. For women with gestational diabetes, they should also be managed by the local diabetes and pregnancy team, and this may be in a shared care setting. They require education and support, and it's often quite a stressful time when they are being given the diagnosis of gestational diabetes. They, like women with pre-existing diabetes, need adequate dietary assessment, advice and support, aiming for a nutrient-dense, balanced diet, including adequate calcium, which may be beneficial for also reducing preeclampsia risk. Adequate carbohydrate is essential during pregnancy, preferably of lower glycemic index. A 10 or 15-minute walk post-meals may be helpful in controlling postprandial glucose peaks. And glucose monitoring is again advised, usually with a glucose meter with finger pricks, but an increasing number of women may choose to use self-funded continuous glucose monitoring, but it is very important to make sure any use of CGM is interpreted using pregnancy targets, and in the context of gestational diabetes, there should be exceedingly high time in the tight pregnancy range, not just accepting the minimum amount recommended in type 1 diabetes. If the glucose levels are above target, they should be commenced on medication, and this may be metformin, but even if metformin is used commonly, they will still require insulin. And again, the regimen will need to be adjusted to their personal needs and doses adjusted accordingly. And again, they may have high insulin requirements. So it's a challenge for managing women with diabetes in pregnancy outside major centres, and there is no easy solution. For women with pre-existing diabetes, particularly those with type 2 diabetes, they should be linked to a specialist diabetes and pregnancy service, and clearly this is easier now that there are telehealth options. And it should be considered making a shared care arrangement with a major centre if at all possible. Also, particularly for women with type 1 diabetes, there should be consideration for transferring them to a major centre ahead of delivery, and often this is by 34 weeks or earlier if there are additional concerns. So, following pregnancy, for women with pre-existing diabetes, one of the first discussions, which may seem somewhat surprising, is to raise the decision on contraception. They will need a lot of restabilisation of their diabetes management, and prior to being discharged from hospital should be given contact information for assistance with stabilisation, guidance as to the frequency of ongoing glucose monitoring, and parameters for seeking advice between appointments. They should also have a formal review appointment within 6 to 8 weeks. Ideally, all women with type 1 diabetes should be in the care of specialists, and as should women with complex type 2 diabetes. Women who have had gestational diabetes should be encouraged to have a review with their general practitioner within 2 months of delivery, and hopefully the GP is being provided with summary information and a follow-up plan at discharge. They should also be given long-term diabetes prevention strategies for themselves and for the broader family with regard to diet, exercise and weight management, and clearly this is setting up the plan for long-term management for these women. This slide is available for you following the presentation, and it does demonstrate the stratification of cardiometabolic risk for women with just previous gestational diabetes and recommendations for degree of follow-up. Similarly, this is also available, and this slide demonstrates the impact of maternal hypoglycemia and obesity in pregnancy, on the long-term metabolic consequences of the offspring who have much higher rates of overweight and abnormal glucose tolerance by young adulthood. So in summary, diabetes in pregnancy has impacts on the pregnancy outcomes and future health of the offspring. Pre-existing diabetes is particularly high risk and specialist care essential. Pre-pregnancy planning and optimal glycemic control before and after pregnancy are critical. Diabetes medications that are considered safe are insulin and probably metformin. Gestational diabetes is associated with an increased risk of future diabetes and cardiovascular disease, so modifiable risk factors should be addressed pre-pregnancy, ideally, and long-term follow-up will include planning for future pregnancies, reducing modifiable risk factors, monitoring of glycemic status, and optimising all cardiovascular risk factors. As I've already said, for the children at this time, there is no recommendation beyond a healthy lifestyle, but this does need consideration and is one of the goals of the National Diabetes Strategy at present. Thank you.
Thank you, Glynis. How about during transitions of care from paediatrics to adulthood? Professor Alicia Jenkins will share common challenges faced during this transition period and how they can be mitigated.
I'm Professor Alicia Jenkins. I'm an adult endocrinologist, but I have experience in the clinical care of children with type 1 diabetes. I'm pleased to be speaking about the important topic of the management of diabetes during transition from paediatrics to adulthood. Transition is the purposeful planned movement of young people with chronic conditions such as diabetes from child-centred to adult-orientated healthcare systems. In diabetes, this usually means coming from a multidisciplinary care, such as a public hospital diabetes clinic, to an adult public hospital or a private practice or general practitioner. Wherever it is ideal that this service has, as well as medical care, access to a credentialed diabetes educator, dietitian, and other healthcare professionals. This transition usually happens in the diabetes space between 18 and 25 years of age, so usually after completion of secondary school. This is relevant to youth with type 1 diabetes, but also increasingly so to young people with type 2 diabetes and other less common forms of diabetes. The setting of transition is at an age where the brain is still developing, which it is until about the mid-20s, and is a time when some people engage in high-risk behaviour. As shown by the type 1 diabetes exchange data, this is often at the highest hemoglobin A1C of the diabetes life course. It is a time when young people are developing knowledge about their diabetes and the healthcare system and about self-advocacy and independence. It's a time when there are many life changes, such as moving from schools to jobs, moving out of home, and there are often competing priorities in the young person's life, such that their diabetes care is not often as high on the list. There's certainly the need for ongoing self-care, diabetes medicines and monitoring, as always, and particularly during this time of change, it may be even more important. Pleasingly, most Australians with diabetes do transition well, but there's a small subset who do not. It's recognised that there are some high-risk subgroups who may not transition to adult care as well, and this includes people with diabetes who are isolated socially or geographically, Indigenous Australians or people from culturally and linguistically diverse groups, people with type 2 diabetes, people who have poor attendance to their youth services, if they've got multiple comorbidities, mental health issues, low health literacy, or high hemoglobin A1C. These factors have been associated with greater risk of a poor transition. There are recognised differences between adult and youth services for diabetes. In the adult service, there's less parental participation, so the young person must attend to their scripts and appointments and lab tests. There's often less time at each clinic visit, and often the clinic is at a new location for the person with diabetes. There may also be less allied healthcare professionals on site, particularly if the person is being seen in private practice. There's also in adulthood more emphasis, not just on glucose, but other non-glucose risk factors such as blood pressure and cholesterol, and more frequent screening for the early signs of diabetes complications. The lab tests often require venipuncture at a pathology lab rather than in-clinic finger prick point of care testing. In the adult service, there may be less people experienced with the technology compared to in the paediatric sector. And for the young person, there may be higher costs of their CGM and need for private health insurance if they wish to acquire or upgrade an insulin pump. The risks of transition are well recognised, the major concern being lost to follow-up, or, whilst not being completely lost, being less engaged with their healthcare. And Australian data from 2012 showed that there was about 24% of people were less engaged with their healthcare after transition to adult care. And a lot of this happened 1 to 2 years post-transition. About 9% of Australians became disengaged with diabetes care. Other factors associated with transition include worse metabolic control, in particular higher hemoglobin A1C levels, which in the developing brain can contribute to some subtle physical damage to the brain and neurocognitive changes. It's also a time where there's a greater risk of worse mental health, more acute complications such as hypoglycemia and diabetic ketoacidosis. There's more emergency department use and more hospitalisations, such as due to severe hypoglycemia and infections. There's also risk of progression of chronic complications, particularly if they were already evident. And whilst rare, there's increased risk of premature death, such as due to severe hypoglycemia. There are various models of transition, and we have various models in our country, such as transition from young to an adult clinic in the same hospital, such as is available at Monash in Victoria. Most often people will transition to an adult service elsewhere, which may be in another public hospital. They may have a period of adult clinicians attending their youth services before transfer so that they can the young people can get to meet the adult doctor who will be treating them. Sometimes there are transition clinics or young adult diabetes services, YADS. We used to have one at St Vincent's Public Hospital in Melbourne. It is now transitioned to an all-ages type 1 service. And many models include a transition coordinator, often with digital resources. In Queensland, there is a state guideline which has the common aspects to any transition of planning, preparation, transfer, and ideally follow-up. And in Queensland, they suggest having a transfer clinic between the paediatric and the adult clinic. There's a systematic review that was conducted recently of 14 studies which identified 3 models of care: structured transition education program, a multidisciplinary team transfer support, and a pure virtual clinic model. And for each of these 3 types of models, some of the results were positive and others showed no benefit, and no model was superior to the other. Irrespective of which model is used, they're key team members and resources. And the most important person, obviously, is the person with diabetes, and their family and caregivers are obviously also very important. Other key players include tertiary referral youth and adult diabetes care teams, multiple private healthcare practitioners. Their general practitioner is key. There's multiple nurses who are relevant, such as credential diabetes educators, practice nurses in general practice, and community nurses. Mental health care professionals are key, as access to medications and continuous glucose monitoring and pump consumables are important for people, particularly with type 1 diabetes. Pharmacists and the NDSS are also important, particularly for those who do not transition well. Emergency departments, including virtual emergency departments, can be very, very helpful, as can urgent care clinics, nurse on-call services, the ambulances, and other first responders, who we need to make sure are well educated about diabetes emergencies. Communications such as SMS, phone and emails and digital resources are very important, as is youth peer support. And also for particularly vulnerable people such as homeless, we need to ensure that organisations such as Streetside Medics are well resourced to support young people with diabetes. Some recommendations are to start early to prepare the person with diabetes, to educate them about the difference in diabetes care in the adult versus the paediatric sector. It's important to have positive collaborations between the paediatric and the adult care team, and absolutely to keep the GP involved, particularly if the person doesn't transition well. A transition coordinator can help improve transition rates, the change in hemoglobin A1C, and reduce the risk of those adverse acute complications. Wherever the person is transitioning to, there should be a transfer of detailed medical records to their next intended service and also to their GP. There should be written documents which also include information for the young person, such as how to make an appointment, out of hours contact and what to expect, and digital means as well, and education are also valued. We definitely need more research so that we can translate the best results. The last review that I could find was of our national activities in this space was in 2007. I suggest that we need an updated national review, and we include some of the particularly vulnerable groups, including youth with type 2 diabetes, high-risk ethnic groups, and people living in rural and very remote areas. We need to include a broad range of stakeholders and certainly use co-design for people with diabetes and others involved. And we need to examine a broad range of outcomes, not just transition rates, but also long enough follow-up, and include control groups and the health economics of it all. So in summary, most youth with diabetes will transition into the adult service as well, but there are major adverse consequences for those who do not, and there's challenges for all who transition. Medicines and monitoring of glucose and ideally of ketones, particularly for people with type 1 diabetes, is essential. The transition process should be started early and include education and connection with the adult service. There should be some contact maintained with the person with diabetes and their GP, and if permission is given, with the family member. There should be flexible, patient-acceptable means of contact, and people involved in the transition should know the range of resources available, such as virtual emergency departments, digital scripts, and other services. And it's ideal to have further dialogue and research so that we can offer the best possible outcomes for young people with diabetes. As Elliot Joslin, the American diabetologist, said, the effort of diabetes care is great, but the reward is also great, as is practicing in this area. Thank you very much again for having me, and I'm happy to be contacted on that email if I can be of any assistance.
Well, thank you, Alicia, for that very interesting presentation. I think they were three great presentations. And they feed very nicely into our next panel, which will take a deeper dive into diabetes management, particularly at the transitions of care. And I'm delighted that we've got an expert panel that'll help us really unpack some of the themes here. So online there, we've got Associate Professor Spiros Folanos. He's the Director of the Diabetes and Endocrinology Department at the Royal Melbourne Hospital. Welcome, Spiros. We've also got Associate Professor Glynis Ross, and Glynis is lead for the Diabetes in Pregnancy Service at the Royal Prince Alfred Hospital here in Sydney. We've also got here in the studio Dr. Michael Hancock. He's an endocrinologist, also pharmacist first, which I'm pretty cool about. He's has a number of roles, working in a clinic, living with diabetes and endocrinology, but also works at the Royal Perth Hospital. And Michael has also generously shared that he's living with type 1 diabetes. So thank you, Michael, for being here. And really delighted to welcome back, and joining the panel again is Dr. Phoebe Holdenson-Kimera. She's a medical advisor for the Australian Commission on Safety and Quality in Healthcare, and of course also a general practitioner. So we're really delighted to have such a fantastic panel. So the World Health Organization, in its Global Patient Safety Challenge, Medication Without Harm, really highlighted 3 key areas where medication safety was really at a critical point, and transitions of care was right within that wheelhouse. The other area, of course, were high-risk situations. So if we think about people living with diabetes, as we've heard in the presentations today, there are a number of high-risk situations, and certainly one of the highest risk areas would be around transitions of care. So Spiros, I might start with you, if that's okay, and just seek some of your observations around the challenges of people living with diabetes transitioning into hospital care, perhaps undergoing procedures or the like, and then of course transitioning out. So maybe you could share some of your experience in managing people living with diabetes in that setting.
Thanks very much, Andrew. I think clearly challenge is that diabetes unfortunately often becomes more unstable with acute illness or surgery. So ironically, we see the very worst of diabetes in hospital. So with the great lability of glucose control, we have risks of severe hypoglycemia and hypoglycemia, even ketoacidosis, and adverse outcomes in hospital. And so with that comes a need to adjust the diabetes medications. And at that transition point from home or the community into hospital, almost invariably necessitates a change to diabetes medications. And then day to day within hospital, things are varying. And then, the problem is one of consistency of approach to that medication management, certainly within the hospital, but also with the transition back to the community, because a lot of chopping and changing of medication. So, it's something which on the surface looks very simple, but it's just incredibly challenging to deliver highly consistent, high quality and safe care to reduce the variation in practice and outcomes.
Thanks, Spiros. We might come back to you in a minute just to think about what might be, best practice for managing medicines in that situation, and also, of course, the role of effective communication. But Phoebe, I might throw to you. I'm sure in your role as a general practitioner, there'll be times where you might even be surprised that one of your patients has been in hospital, and you might receive a discharge summary, some information about that. Tell us a bit about your approach, or maybe some of the things you see as your patients you care for are coming out of the hospital setting.
So Spiros is absolutely right. Many of my patients with diabetes who go into hospital do come out on different medications, whether that's related to their diabetes or related to some other aspect of their health. And you're absolutely right. Often it's at the time that I receive the discharge summary that I find out about that. Now, many of our patients with diabetes actually live with quite a bit of multimorbidity and complexity. And what I love to see as a GP is actually to know about that admission and the upcoming discharge even before they come out of hospital. So that can be as straightforward as a short phone call with the team's intern. It might be that the patient themselves has been encouraged to make an appointment within a few days of the discharge for medication reconciliation, but also just to discuss what's happened in hospital and to help them make sense of what's happened. And I think the really important third aspect for me as a GP is to involve the community pharmacy. So those are the 3 players that really need to work together cohesively, because that first week that somebody comes out of hospital, I see just so many things slipping through the cracks, or almost slipping through the cracks.
Sure, and it's a really, if we think about a high-risk situation, that's likely to be one of those, isn't it, when it comes to medication safety?
Oh, absolutely. And it's just incredible how confusing and uncertain that period can be for patients. So we really need to be proactive in setting all of that up so that it succeeds.
Excellent. Thank you for those insights. We'll circle back to a few of those in a moment. But Glynis, I might throw to you. You really help manage special and complex health situation and very special patients, of course, are mothers that might have gestational diabetes. So I wonder if you could give us a bit of a sense of, I suppose, your experience, particularly around medication management during that transition, perhaps into hospital, and also after they've delivered their child and managing their ongoing care afterwards.
Okay, so just to clarify, just on terminology, so we've got women who are known to have diabetes prior to the pregnancy, so
Yes.
type 1 diabetes, type 2 diabetes or other, and then we've got the actual definition of gestational diabetes, which is diabetes which is first recognised during pregnancy. So they're very, very different scenarios. So for the women with pre-existing type 1 or type 2 diabetes, and they only comprise around 1% or perhaps slightly less of all pregnancies. So it's not huge numbers, but these women have still much worse pregnancy outcomes than the rest of the population. And there are many needs for these women. One of them is really encouraging these women to pregnancy plan. Ideally, obviously, all women should plan all pregnancies, but particularly women with pre-existing diabetes, to reduce the risk of miscarriage, being on the wrong medications, reduce the risk of congenital anomalies, with the rates of congenital anomalies being on average 4 times greater for pregnancies that are complicated by pre-existing diabetes than background population, and also to reduce the risk of late stillbirth, which unfortunately does correlate to a large degree on poor glucose control coming into the pregnancy. So pre-pregnancy planning is really, really important, and trying to strongly encourage women with pre-existing diabetes to be using safe, appropriate contraception unless actively trying for pregnancy. So that's very much one of the things that needs to be highlighted. The second thing is, if they've got pre-existing diabetes, the majority will be on some form of medication for diabetes itself. Insulin is clearly safe, but they may need a change of insulin regimen. With the data coming through, particularly in one of the automated insulin delivery systems, and the general trend for increasing uptake of automated insulin delivery systems for people with type 1 diabetes, that is now another area of management. For the other diabetes medications, the only one that we would really like women to be coming into pregnancy on would be metformin. There is a cloud over GLP-1. We don't know whether it is concerning for increasing congenital malformation rates or whether perhaps it's safe. So animal data look concerning so far. Reports in humans is a bit mixed, and it may be just a numbers issue at the moment. SGLT2 inhibitors, not safe, and sulfonylureas, if they fall pregnant with them, probably okay, but not to continue in pregnancy. So we really do need to be reviewing their diabetes medications. Another issue is that a lot of the women will be requiring other medications, so for hypertension management, lipid management, and these again need to be reviewed. We don't really want them in early pregnancy on lipid-lowering therapy, and antihypertensive need to be pregnancy favourable ones. So again, the whole package of medications needs review. And on top of that, the advice on taking higher dose folic acid than is recommended for the rest of community, again, to try and reduce congenital malformation rate. So that is in women with pre-existing diabetes just coming into pregnancy. Okay. And most of the large services do offer pre-pregnancy planning to try and facilitate that, because it is a complex area. There's also on the NDSS website, which is the National Diabetes Services Scheme, so funded by Commonwealth Government, run by Diabetes Australia, there is information there in checklists on pre-pregnancy planning. So these can also be used as conversation pieces with women, and I think it also helps health professionals know what things they need to cover. So that's the coming in for those women. If we go into gestational diabetes into coming into pregnancy, again, ideally women, if they're planning pregnancy and are attending their primary caregiver, it would be good for them to be presenting ahead of planning pregnancy, being assessed for, again, any medications they're taking. Are they taking the recommended folic acid? What are their risks for medical conditions, particularly, can they modify lifestyle? Do they Are they at risk for diabetes? Could they have already abnormal glucose tolerance pre-pregnancy? And doing some risk assessments even before the pregnancy to reduce risks, and discussing issues of the high rates of gestational diabetes, particularly if they've got known risk factors. So I might stop there. That's just the coming into pregnancy bit.
Thank you. And I think that also highlights some of the important complexities around this special group of patients. And you've really nicely reflected there the breadth of issues that need to be dealt with. And a lot of that's about awareness and preparation. And of course, understanding the unique risks of those medicines in that population, both to the mother and of course, the unborn child. Maybe just to circle out each of our panelists, Michael, I might just check in with you. I appreciate you bring a number of perspectives to our conversation today. But one of the ones we were discussing too was, if we think about from a transition of care point of view, the young people that you care for perhaps first meet as children diagnosed with diabetes early on, following them in their health journey, of course, their transition to adulthood. Of course, we know they move through a paediatric system, if you like. Maybe in primary care it's similar, but certainly from a hospital point of view. Maybe you could just reflect on some of your observations, particularly around medication management for those younger people as they get older and things you've seen and experienced.
Yeah. No, thank you very much for that. And I think, Andrew, a really clear point to make here is the complexities that we're talking about in all these different areas. And it doesn't get more complex than adolescence. I think everyone, either whether you've got children at home or whether you deal with them in medical care. And then of all conditions out there, particularly type 1 diabetes, which I think is probably one of the most complex chronic conditions to live with. I think we clearly know that glycemic control for adolescents is a time where we kind of have a greater risk for hyperglycemia and kind of excursions throughout. And when we get to this really high risk period of transition, there's a significant change going on. We've got this significant change of the healthcare group they're seeing. Obviously, it'd be fantastic if they come and see myself. I can engage with them well. But, you know, there's moving from a system where they're able to see a team maybe multiple times throughout the year very happily to either being within a private system or a public system where they may not be able to do so as evenly, perhaps even not as with as much wraparound service when it comes to the ability to have social work following them up if they were to perhaps not attend clinics or have difficulty attending clinics. That's just simply the medical system in itself that is a big complexity for them. But let's not forget they have to manage type 1 diabetes, and it's a vastly different world now. They now are going to attend either university, TAFE. They have to be managing their diabetes around these scenarios with a boss, colleagues, new friends, new relationships, living with things like alcohol and drugs. This simple management of type 1 diabetes and insulin is definitely not so. And then I think for those people that are out there dealing with all of that, they then have to deal with not just the change in the medical system and who they're seeing, but even just what's possibly available to them. I think as endocrinologists, particularly in the adult world, I've seen this magical land of pediatrics where we have quite a bit different funding and support for things like insulin pump technology with our hybrid closed loop pumps, which have had really an amazing impact on glycemia, in particular in this adolescent group and some of the data we've seen. But in the adult world, access to these therapies is purely bound to those that have private health insurance and the risk of inequity there. So I think this is type 1 diabetes in particular, which, you know, there's a significant risk of progressive worsening glycemia and difficulty in achieving tight glycemia as we kind of progress at that point. Now that's type 1 diabetes, but there's also type 2 diabetes, I think, which we need to start paying attention to when it comes to this management. So type 2 diabetes is now becoming much more prevalent, unfortunately, in our younger population, adolescents throughout to transitioning as well. Patients with type 2 diabetes in the adult setting is something we see quite commonly, but I think what we more commonly see in our clinics may be fairly complex, multimorbid type 2 diabetes. One thing that I'm quite concerned about is a young child that's now a young adult with type 2 diabetes may only have 1, 2 medications and may not appear significantly multimorbid, I guess, But to me, that's an extremely high-risk individual that's already had multiple years of diabetes at a very young age, and we're very concerned about what that progression is. So that person also has to navigate all of these other changes when it comes to their employment, their friends, their relationships, but then also think about their future morbidity, mortality risks. And we need to make sure that we are wrapping ourselves around these individuals too, to make sure they set up strong connections with GPs and other clinical teams.
And of course, family members obviously have a critical role there too in navigating that space. And I'm assuming you work closely with them as much as young people as well.
Yeah, absolutely. So what probably struck me the most when I was doing a pediatric kind of term, I guess, was how involved we were with the families, and obviously how extremely important that was.
Yeah.
Whether that's type 1 diabetes, as again, I wrap around support there, but type 2, we're kind of talking about the family unit with psychosocial things that may actually be, I guess, feeding into that type 2 diabetes and the management there. I think in the adult kind of setting, we're not as commonly bringing in families. And I think that that's something that's really important to highlight. And just complexities as well. We haven't even talked about how there's obviously a greater proportion of Indigenous population with type 2 diabetes. And the culturally kind of competent way we need to go about management in the pediatric and the adult space there. So that's another big complexity.
And from a resource point of view, do you feel if we take that group of culturally, linguistically diverse and also First Nations people living with diabetes, do you feel we have the resources and support to, provide the education, direction and support for those patient groups?
Do we have it available in Australia, the world? Yeah. Do we have it available for what we're actually providing? No. I think the paediatric setting, particularly at Perth Children's Hospital where I was at, was amazingly well funded in aspects, but also an amazingly well-oiled and functioning team. They did an amazing job. Certainly in the adult space, I don't think we kind of do have that. Another big thing would even just be the simplistic thing that a lot of those patients are actually going out quite far away from Perth, and it's extremely hard for us to connect. And the difference with paediatric versus adult was if they were out in Fitzroy Crossing, or in some cases hours out of Fitzroy Crossing, we would actually know who to contact and how to identify and find them and bring them in, or fly them down, or whatever we kind of needed to do. Whereas that simple idea there certainly doesn't happen in the adult space. And that's not just funding. I think that's also just our systems that we have in place. And I'm sure it's fairly similar for each state as we go around.
Optimal dosing, use of technology, information, culturally, linguistic diverse, a few themes we'll pick up in other parts of the NMS as well. So really good response. Spiros, I might throw back to you, just picking up on one point that was made there around culturally and linguistically diverse populations. And I'm sure in your practice, and given the multicultural nature of the patients that you see, I wonder if you could talk about maybe some of the challenges and also some of the opportunities and solutions for managing people living with diabetes in your practice setting, particularly those from a diverse cultural background related to their medicines and management.
Of course, yeah, it's a highly relevant issue in the acute setting. In fact, 25 years ago, I did a study here at the Royal Melbourne Hospital, which we established that 1 in 3 inpatients had a language other than English as their preferred language. That was back in 2000, and it's still very much the case here. And I presume it would be the case for most of the metropolitan centres at least. So it's incredibly relevant. Again, very challenging. And what it means is that the systems that we have in place need to be really slick at handling that situation. So, for example, let's think about the transition from primary care or community into hospital. The medication reconciliation piece needs to be really strong, and clearly you need to access interpreters and information systems to ensure that there's no miscommunication or misunderstanding in relation to what diabetes medications this person is on. And then, as I said, with the acute setting, because you have time pressure, everything's compressed into a very short period of time, lots of change management, plus the competing pressures of other illnesses and pathologies and to deal with in the socio-cultural context of this person, then the communication piece is absolutely paramount. So clearly we use interpreters. In fact, we had some data presented here at the Royal Melbourne, and our top 3 languages at the moment are Mandarin, Italian and Greek, so they're on-site interpreters for those languages, but sometimes we have to use telephone interpreters. As you can expect, we try not to use family members, ideally, to ensure that the quality of the translation is good. And then, of course, we have literature which is translated in also various languages, explaining elements of inpatient diabetes care, for example. And clearly, you can see that the multidisciplinary team is absolutely paramount in all people with diabetes admitted to hospital, but especially that comes to the fore with people from diverse backgrounds, where you need, for example, the pharmacist to do some high quality work with the medication reconciliation, the nutritional piece, and the dietitian, nurse educators, because as was mentioned before by Michael and Phoebe as well, there's just so much technology now being used for diabetes, and that comes with additional challenges. And we're using a lot of video technology to demonstrate how to insert a CGM device, for example, and elements of using some pump therapy. So yeah, it's exciting, it's fascinating, but yet again, there's that word, challenging.
You mentioned that the recent Australasian Diabetes Congress is really starting to make some progress towards, I suppose, optimising the management of diabetes in people living with diabetes in the hospital setting. Do you want to just share a little bit of those insights?
Sure, Andrew. So I hinted with my first reply to you that variation in care is a big theme. Obviously, many elements of acute practice, but especially in diabetes. And diabetes is one of the most variable conditions known to us. And therefore, we believe there needs to be benchmarking to establish certain understanding of the landscape in relation to acute diabetes care, and especially in relation to the medication management, so we can understand how much variation there is within hospitals and between hospitals. And at the moment, we don't have such a vehicle in Australia. For example, the United Kingdom, there's Nadia England, established by Professor Jerry Raymond, who's visited us a couple of times. And that really has changed the landscape for diabetes care in hospitals, and certainly when it comes to consistent medication practices. And we strongly feel, as the health professional community in diabetes, and backed up by the Australian Diabetes Society, that we're really keen to set up such an initiative in Australia. Yeah, that would involve basically us ideally doing what's been done in England, which is doing perhaps an annual audit of diabetes care across hospitals, and that would enable us to understand what's happening within our local context and between hospitals.
Thanks, Beros. Very interesting development. I'm sure people will be looking out for that. Phoebe, I might throw back to you around, I suppose, a bit of a different theme that cross-cuts a bit of this. This is about how we best support individuals to be empowered to manage their diabetes medicines. And what are some of the approaches you're aware of, or maybe steps you've been involved in this area in supporting patients to understand their medicines, and particularly around the transition of care to get the best outcomes?
Yeah. So I think that the more that a person understands their diabetes, what it means for them and their medications, the better equipped they are to be able to understand any changes that are made, but also ask the right questions. So before they undergo a transition of care from the community, I would say it's really important to be developing those chronic disease management plans with their GP. That means that they're actually taking the time to sit down on a regular basis and sort of take stock of where things are at. But also set their goals of care, and then that means that the GP, the person, the pharmacist, potentially the diabetes educator, the dietitian, or the podiatrist, all of those people are actually on the same we're all on the same page. And ideally, if they were to go to hospital, they would also take that document with them. Right. So they don't need to necessarily reiterate all of that. And then I think it's just about taking the time to, patient education takes time. We might explain it once, but that person might be just recovering from a surgery. They might have other issues that they're coping with. And so providing written information as well to accompany that. But then again, having that opportunity after the discharge to touch base with the GP and reinforce those messages or clarify them. Because what we know is that after a particular consultation, people might only recall 20% of what was said. And so it's not to say that those things aren't being articulated in the hospital. It's just that as a GP, what I'm noticing is that when people come out, there is a huge amount of confusion. And then I would say an early home medications review with the community pharmacy, if that's available. Then that means that the pharmacist can take the time and go, oh gosh, there are all these boxes of old medications that you don't take anymore. Let's take those away, Oh, let's take the time to explain, how this new insulin device works and all of that. So I think not making assumptions, giving people the time to ask questions. And I always talk about actually taking a list of questions that somebody might have to their next appointment, just to facilitate those conversations.
And Michael, do you get many patients come to see you with a list of questions that you work through when it comes to their medicines?
Yeah, it's interesting because obviously I think when patients leave hospital, they'll have a discharge summary, which is often obviously addressed to the general practitioner, which is probably the most central core person, which is extremely important. But quite often I'm brought into the loop if the patient's advocated enough to be kind of saying, can you please call my specialist either in there, and that happens, or I kind of wait for that next appointment when it comes up, and then sometimes you do come across various surprises at that point in time. So I think it all comes down to communication. That's really a central theme that's probably coming out through a bit of this. And just building on what Phoebe was saying as well, like I guess we're talking a lot about type 2 diabetes and things, but patients advocating and thinking about that high risk transition period with type 1 diabetes and insulin in the inpatient setting is actually a big thing. So when you've got either perioperative care, pre and post, and a lot of building technology and complexities now, we've got patients who really are the masters and the people that know the most about themselves, more than most of the doctors in the hospital. And we almost need to be advocating for them to be able to advocate for themselves and give themselves the best possible care. And that's just another important core thing to think about.
Excellent. We're getting towards the end of our time together, but Glenys, I know that you have particular insights into transitioning and supporting the transition of the patients from an urban environment, perhaps at Royal Prince Alfred where you work, to a rural area. And I wonder if you could give us maybe a couple of quick insights into some of the medication challenges there and maybe some of the solutions.
Yeah, well, I think it's not so much just even the medication challenges, it's providing adequate diabetes support. So
Right.
obviously in urban areas, we've got a lot, especially the major hospitals, we've got a lot of additional supports and very multidisciplinary teams. As we move further out into remote and rural, there are very limited health professionals around, and it's important to try and work out for each individual what the best supports are going to be there for the diabetes, because a lot of it is going to be relying on the primary caregiver, with the GPs, with diabetes educators if they're there, the pharmacists that are there, to try and support them with all of the medications. And following a pregnancy, they're going to need different medications to what they've just been having during the pregnancy. So they're needing review of their medications, the dosing, and what's appropriate. And again, in the context that they should be going back onto some version of contraception, so further discussion. So it is actually quite difficult, but really important to try and provide the best support to each individual woman for the situation that she's heading back to.
And just as we close, Phoebe, I know there's also been some really important developments around transitions of care here at the Commission. Do you want to just share those?
You may remember that there was a whole session talking about the need for a national medication management at transitions of care stewardship framework. Well, very happy to say that that has been developed by the Commission and released just recently. And that's really looking at ways that the system can better coordinate and have governance over this very, very high risk time where people with complexity, with multimorbidity and high risk medications are supported as they come into hospital, but also as they transition back to the community. So I'd encourage you all to have a look on our website for that resource.
I think you'd agree that's been an excellent panel discussion, particularly about the multidisciplinary care of people living with diabetes during that transition from different healthcare settings. Many of the things that we spoke about today are also going to be available as a compendium of resources on the Commission website, particularly related to transitions of care. So I think you'll find that really useful if you'd like to take a deeper dive. But lastly, I'd just like to thank our panelists. Thank you, Phoebe, for your time today. Thank you, Michael.
Thank you.
Thank you, Spiros.
Thanks very much.
And thank you, Glenys.
Thank you. You're welcome.
Managing diabetes medicines across different populations is complex and often challenging. Returning from last year, Professor Jennifer Martin will present her perspective on this important topic.
Hello, I'm Jennifer Martin. I'm a clinical pharmacologist and a general physician and president of the Royal Australasian College of Physicians. And I'm really delighted to be here today for the National Medicine Symposium 2025. It's a fabulous meeting and we're talking a lot about diabetes. As a pharmacologist, I'm really interested in medications and their effects on people from different population groups and different physiology. So I'm here today to give you a pretty quick overview of some of the pharmacological considerations for diabetes medications for those special population groups, and particularly as those number of diabetes medications increases. Overall, some of the general messages from today are the same that we use with other classes of drugs. That is, we need to have a good understanding of population groups, be they paediatrics, the elderly, people of different cultural and ethnic backgrounds, different diets, and people with different physiology. And we need to understand, therefore, how these medications might be absorbed, distributed, metabolized, or excreted, because all of those things affect the relationship between a drug, its side effects, and its benefits. As you'll know, there's an increasing number of medications from a wide variety of different drug groups that are now available to treat diabetes. While on one hand, this seems pretty exciting because we've now got new therapies, it can actually add some complications, mainly because the doses that we sometimes use in clinical practice are not always those that we studied in clinical trials. We're also often using them in patients that do have diabetes, but may also have a lot of other medical issues, such as heart failure, such as kidney disease or other organ disease. And therefore, some of these drugs have side effects that turn up in doses that weren't actually seen in the original registration trials. So when we see new medications come onto the market, it's important to know how much more benefit these drugs will have compared to the ones we're currently using. What sort of doses should we use in all these different population groups? What are the drug interactions? And how should they actually be fitted into the armamentarium that we have for treating people with diabetes? In addition, and you'll increasingly see that there are drugs out there that are used to treat people with obesity. Some of those people don't actually have diabetes. So we're seeing a lot of side effects and a lot about these drugs just from a more broad use in the diabetes population. Some of the problem, however, with this overlap is that some of the trials for these drugs in obesity may not affect the population with diabetes in the same way. And you can see here that there's a huge number of drugs that are available and a huge number overseas that are likely to come to the Australian shores. Some of these also have different modes of administration. We know there are significant differences when we take a drug orally, if we inject it subcutaneously, or take it in some other injectable form. That can be a real problem, particularly if the drug data is for people with obesity and we're actually using it for type 2 diabetes in people that may not be that obese. Some of the principles around how we should use these drugs in people with diabetes are actually pretty standard rules in terms of how we approach quality use of medicines for other classes of drugs. I've just got here all the different classes of drugs that we've now got available for diabetes. And I think it's really important just to sit here for a minute or two and look at the slide, because you can see there are significant numbers of receptors and pathways which are differentially blocked. One of the other interesting things just looking at this slide is that you can see that for many of them, the dose response curve is not flat and it's not always linear either. That means that for some of these, as we get near the top of the dosing range, we're going to have an effect that's actually quite unpredictable. So we might get more side effects than we expected, or we actually might get a significantly greater lowering of the blood sugar. This means that for each patient, we have to really think about their physiology and what's going to happen as we increase the drug dose, particularly in terms of side effects and in interactions with other medications. For example, if you're on a medication that has an effect on sodium for some other disease that you have, and you're not now taking a loop diuretic for heart failure or you're taking one of the SGLT2 inhibitors that do have an effect on the sodium glucose pathways, you might actually see quite a different effect to someone who is not on, for example, a sodium retaining drug such as a steroid. So that's why we really need to know about these classes of drugs, what they do, what the dose response curve looks like in general, and what we expect the dose response curve to look like for our particular patient. If I go back to the quality use of medicines slide again, I think this is just one that we really need to reiterate. There is lots that we can learn about each of these particular drugs and how they're absorbed, how they're used in the body, but we do need to really not ever lose sight of the fact that we need to implement quality use of medicines principles into everything we do around dosing. And we've got some of these points on the slide here. Just to recap really quickly, we need to make sure that the medications are used safely and effectively to achieve the best outcomes for the patient in front of us. Those medications should be based on individual needs, and that means taking into account people's other health conditions. We need to make sure that the medications are able to be taken at the time that we prescribe them and the dose that's prescribed, and that we're actually aware of how the patient is likely to respond to some of the adverse events. We do need to minimise the risk of adverse drug events. That is to say that if we know the patient has renal failure and we're wanting to give people a sulfonylurea, that we're actually aware of what might happen when we increase the dose and ensure the patient is aware of how to manage that. Another common drug for which that applies is metformin, and we think that people are actually getting pretty good at talking to patients about the importance of stopping their drug or reducing the dose if they actually get unwell. There are other factors that affect medication adherence, and this is particularly so for our older population, such as cognitive impairment and such as complexity of regimen, particularly drugs that are taken at different times during the day, or drugs that are taken less frequently, such as once a week. And I think increasingly in clinical practice, we're realising that for older people, a once-a-day drug appears to be easier to remember than a drug that's taken much less frequently. Maintaining consistent and coordinated medication management across different healthcare settings and with different prescribers is also important. And we know that communication can be quite difficult and disparate, particularly between a hospital system and private healthcare, or with our general practitioners, or with our pharmacists. So it's important to ensure the patient has set up appropriate medication management frameworks to ensure that we know what drugs they're taking and what dose they're taking. There also needs to be regular individualised assessments, and it's not that uncommon to have people come into hospital, started on a medication for diabetes when they were really obese and struggling to maintain their blood sugar, have now lost a lot of weight and actually are suffering from hypos or having other interactions with their medications because of the significant amount of weight that has been lost. And lastly, goal setting. That's one that we often overlook, but it's really important. What are the goals of care here? Is it a younger person and with their diabetes we're going for really tight control to try and reduce the risk of microvascular complications? Or are we trying, for example, in a person in an aged care facility to reduce their admissions to hospital, to reduce them falling, and maybe tolerating a slightly less rigorous control of the blood sugar? So goals of care, that's a really important issue that we should all as health practitioners be looking at to ensure that we can give our patients the best care. There are some important areas I think that we need to talk about, and that's really around the diabetes management apps that are out there. That probably comes back to our previous point about having individualised care, making sure the patient is aware of what their goals are, and ensuring that everybody agrees on the targets. Now, I know there are others that are speaking about some of those applications, but I think it's really important to make sure we ask patients what they're doing, and when they get specific results on their home devices, what they're actually doing to change their medications. Because actually it's quite surprising how many people use them, and also how many people actually manage and titrate their own diabetes regimens based on a device that they've got access to. So really having everyone on the same page, I think, is very, very helpful and important to reduce adverse events. The other point about that is just that for some people, when they're using those applications for a long period of time, they actually get a better understanding of themselves, their population group, and their physiology and how they're responding to the medications than any of the knowledge that we've got out there in the literature. So often it's quite important to listen to people and to hear how they're using the applications to actually manage their blood sugar. And I think certainly as a practitioner, I've learned a lot from people who can actually manage their application and can titrate their medicines appropriately to that. The last point is another one that we sometimes overlook around quality use of medicines, and that's around either reducing the dose or discontinuing a medication that is no longer needed. And this is particularly so as people age and develop other comorbidities along with their diabetes. It sometimes means that some of their other medications are actually causing potential risk of falls. An example of this might be a younger person who gets started on an ACE inhibitor to help the kidneys, for example, from the effects of the diabetes. As they get older, that dose of the ACE inhibitor might actually be contributing to postural hypotension and might be causing falls. So then we have to titrate the benefit for long-term kidney health with actually the patient's current risk of falling and coming into hospital. And often there's no literature to guide us here. We just really have to understand the patient, their goals of care, their other comorbidities, and some of the other drug interactions and other doses of medications that might also need to be reviewed. The group of older people, particularly those in the aged care facilities, have a lot of chronic diseases, and they often have multiple comorbidities and multiple medications that go with that. I think that's a specific population group I wanted to focus on in my last couple of minutes. I know there's other population groups, and we'll talk about a couple of those to follow, but this is a really big group in our community, particularly as we all get obese and we all age, and it's an increasing problem. If I just summarise it very quickly though, we come back to the quality use of medicines principles, and that's really around what are the goals of care? What drugs do we think are no longer providing a benefit to our patient? What is the appropriate dose for this patient now they're in their last few years of life? Is it quality over quantity? And if we're going to start a new medication, we really need to make sure that we start very low and go very slow, monitoring and titrating, and if needed, to actually reduce some of the doses of those patients' other medications. There are a significant number of tools out there to monitor hypoglycemia and adverse drug events. I'm not going to go into those today, but they're on the slide. And there's many others in the literature. It doesn't really matter which one you use, but the point is really that you need one that will really make you think about, what am I doing with these patients' medications and how can I help to actually streamline, make more efficient and align what I'm doing with the patient's goal of care. The only other point I wanted to make on this slide is actually around sliding scale insulin. And I know we've done a lot of education on this. I know the previous National Prescribing Service, I know the Commission is doing work here. Sliding scale is sometimes used as a knee-jerk reaction to make somebody's numbers look good. And it's often used in facilities even when a patient is asymptomatic and the blood sugar is actually not that elevated and could be managed by increasing the dose of a patient's other oral drugs or a longer acting insulin. So I thought I'd just use the opportunity to remind people that a sliding scale is not appropriate in those aged care facilities, but it does give us an opportunity, if you see a patient on one of those, to review all of their medications and think about how we could actually get better control, if that's the goal of care, without having sliding scale, which really all that does is lead to patients having hypos, and then they get given barley sugars or sugar lollies and end up pushing their blood sugar high again, and we end up with a seesaw of blood sugars which make the patient feel terrible. So if I can encourage you please that if you do see a sliding scale to use it as an opportunity to review the patient's medications and think about what doses you could be using of these medications. The last slide really talks to this point of tight control versus quality of life. And maybe because I work in general medicine, we tend to see people that are older, and this might be information that's slightly different to a younger population, where we do want to look at tight control and really getting that blood sugar as close to a normal range as possible, bearing side effects and other issues. When we're in an aged care facility, we're really looking at quality of life for a patient, and that means that we can tolerate blood sugars a little bit higher. We can also tolerate less frequent monitoring. So that means that we may not have to necessarily do 4 times a day blood sugar monitoring in patients in aged care facilities, unless of course they're unstable or they're unwell, and you might want to do a few more around that period of time. But apart from that, when the patient's stable, you might just need to do a daily or even a 3 times weekly blood sugar to keep those patients' blood sugars in the normal range. As I mentioned, if the patient is a bit fragile or they're unwell, you will need to do more frequent ones. But it's not that uncommon to see patients that are coming into hospital from an aged care facility. People are trying to do the right thing and give people tight control, but they're often coming into hospital because of falls or not feeling cognitively well or some other issue that's related to too many medications, too high a dose, blood sugar running a bit low. The obesity point, I think I've already mentioned this here. The main issue I've wanted to raise here is that there are a lot of side effects for these medications, and some of those around nausea, being off food, diarrhea, other gut issues actually affect the absorption of other medications. So I think we really need to think about that. And just the other issue, particularly from GLP-1 drugs that actually cause weight loss, that sometimes the patient's other diabetes medications need to be significantly reduced, and just to be alert to that. The renal impairment, there's a lot of details on the slide here. It's a very common problem in people with diabetes, and particularly in the older population as well. So just to be really careful when you're using drugs that are renally cleared, to think about whether you need to dose reduce those medications to make sure the patient doesn't get big exposure of the therapies and get hypos. And we do see that again not infrequently, particularly with some of the older medications, but we still see it again from people who use insulin. One of the other important population groups that I really wanted to talk about today was pregnancy. So women that are pregnant. We've known for quite a long time how to manage pregnant women with type 1 diabetes, but increasingly we're seeing women that have type 1 diabetes but are also obese, may have insulin resistance and type 2 diabetes as well. That combination of type 1 and type 2 in pregnancy is an emerging area of literature, and I won't go into it anymore because you've already had a fabulous presentation from Associate Professor Glynis Ross, but I would encourage you to look into this area if you're managing patients with type 1 diabetes that are pregnant, because increasingly we're seeing that some of those patients are insulin resistant as well. I'd encourage you also just to look at the reference that's provided on the slide there at your leisure. Look at some of the emerging literature around safety of those medications in women that are pregnant. And with that, I'd like to thank you very much for listening today. I do hope that you got something out of the understanding the special populations groups, the different physiology that these populations have, the differential effect of some of the drugs, and particularly the drug doses, and people that have got different physiology and different pharmacokinetics based on their backgrounds, and really encourage you to think very carefully about the goals of care and some of those other aspects around quality use of medicines. I hope you have a really good remainder of the symposium, and thank you very much for listening.
Thank you, Jen. The Patient Reported Indicator Survey, or PARIS, health survey recently released by the Commission showed that individuals who actively self-manage their health with their GP have more positive health outcomes and experience. Drawing from her personal lived experience, Rachel Hicks will share her valuable insights on the importance of diabetes self-management.
Thank you for the opportunity to speak at the symposium. My name is Rachel Hicks. I'm a PhD candidate and research assistant at Western Sydney University and a person with diabetes. Interest to declare in relation to this presentation, I am receiving some scholarships towards my PhD research. I have some professional memberships that are part of my diabetes lived experience and research, and over 30 years of living with type 1 diabetes. Before we continue, I would like to acknowledge that I come from a place of privilege. Not only do I have over 30 years of lived experience with type 1 diabetes, and the majority of this with extensive support and continuity of care, but I'm also a university qualified diabetes researcher. I know where to find the knowledge and resources to support me best, and I can afford the tools to best manage my health at home. So my aim today is to share how we can empower those living with diabetes in their self-management journeys with some practical examples you can take away and apply to your team and beyond. Every day I make over 180 decisions related to my diabetes, and that's before breakfast. Here's an example of this in action from when I was literally finishing the edits of this presentation. As you can see, thanks to some clever people in the diabetes community, of which I found through a private peer support group on Facebook, I've been able to program my continuous glucose monitor readings onto my smartwatch. Now, this is very handy with 2 children to care for, where sometimes accessing my insulin pump or phone to view levels or alerts is tricky. I've also included my insulin pump CGM real-time data graph for context. So this morning I gave myself a temporary reduction of basal insulin rates as I was walking from home to the shops and back, because my glucose is very sensitive to physical activity. So I need to prepare in advance as well as consider the after effects. However, I had to time this around my usual breakfast bolus and morning metformin tablets, as well as the predicted drop in glucose I would have from walking home. As you can see, even with a coffee on board that I did not give insulin for, my blood glucose still managed to drop, then resulting in a brief hypo while finishing this presentation. When art imitates life. So keep in mind that while a healthcare professional may see me for 15 to 30 minutes every 3 months, I'm managing this condition for 8,760 hours per year. The question isn't whether patients can self-manage, it's how well we're equipped and supported to do it. People with diabetes are partners in their care, so how you interact is vital. Research shows that the biggest barriers to disengagement of care and self-efficacy are perceptions of negativity, judgment, or stigma from healthcare professionals. In diabetes care in particular, language matters. The removal of stigma and use of strengths-based language is essential. This assists people with diabetes in recognising their expertise from lived experience and enhances their self-efficacy to manage in everyday life. You'll see these slides provide some recommendations you can implement straight away. A fantastic resource for further communication advice is the Diabetes Australia Language Matters campaign. The Language Matters campaign, conceptualised by Diabetes Australia, centres around using person-centred, empowering and non-judgmental language in the context of communication in healthcare. The campaign has since developed into an international movement with guides now available in 15 different languages. This is a particularly important and valuable resource to ensure communication is clear and appropriate. The End Diabetes Stigma campaign recognises the embedded negative judgments, stereotypes and prejudice that are all around us, influencing discussions and decision-making about diabetes. They developed an international consensus on 49 statements of evidence and recommendations to end diabetes stigma and associated discrimination. Organisations and individuals can take the pledge and register in the campaign and access valuable resources to help challenge the status quo and end diabetes stigma. As you saw from my earlier story, there are so many different tools to assist people with diabetes in managing their health confidently. However, regardless of what is available, we need to empower people to choose what works best for them. Whether this is a hybrid closed-loop insulin pump and CGM technology, or multiple daily injections, or a combination of technology and medication. Diabetes isn't a one-size-fits-all condition, and neither is the treatment or tools for each individual. We also need to ensure we have accessible resources for troubleshooting. For many, this comes through initially access to medications and consumables through a pharmacy and the National Diabetes Service Scheme. I like to mention that out of all of those I engage with for my diabetes care, my pharmacist is the one I see the most often. Therefore, having a proactive pharmacist who is equipped with the right tools and knowledge is vital to me. We also have many community-made resources to assist people with diabetes with making choices for the tools that are best for them. In Australia, we have several supportive diabetes advocates who have websites that are great resources. We have Bionic Wookie. Now, David's website is, according to his bio, ramblings about living with medical technology. However, it is a valuable community resource for helping choose tools for diabetes management, with the disclosure of your diabetes may vary. We also have Leon Tribe, a passionate diabetes advocate and researcher exploring how technology and motivation shape diabetes management. and his website reports clear explanations and practical advice for all types of people with diabetes on tools, resources and technology available to assist with everyday management. We know continuity of care and multidisciplinary teams are important for diabetes management, but once the individual leaves clinic and outside of clinical hours, what tools do they have or actively use? Within more recent studies, particularly during COVID-19 pandemics, individuals with diabetes have highlighted that they are actively seeking health information from non-mainstream sources outside of clinical settings. In particular, digital platforms such as third-party apps, social media and peer support are highlighted as fulfilling a knowledge gap that many people with diabetes are experiencing. This can be due to disconnect between primary and secondary care, or the inconsistency of information provided in clinical settings between diabetes and non-diabetes training teams. Multiple offerings of formal and informal support to reduce barriers to engagement with care are recommended, with methods that best suit the target cohort. For example, for many women planning pregnancies in Australia, especially during lockdowns like myself, community-created private peer support Facebook groups such as Bump Baby and Beyond Australia became the village that they sought for their family planning journeys with diabetes. However, for our vulnerable communities, it's also essential that we bring the tools to the community instead, rather than expecting them to locate it. This is because for some communities, connection and face-to-face presence is essential. The Pacifica Preventing Diabetes Program, or PPDP, run through Western Sydney University, provides culturally safe support and resources to the community, equipping them with the tools for long-term peer support in their own homes and churches. Proactively involving those with lived experience in healthcare service delivery, including research, is vital for long-term successful outcomes and an empowered community. However, this needs to be not as an afterthought and not in a tokenistic way. For example, to tick a box for consumer and community involvement for funding. Co-design and consumer and community involvement is key for optimal translational value of projects and community involvement in the project and subsequent opportunities. Research shows lived experience in projects is vital to achieve long-term implementation and successful outcomes, particularly in conditions such as diabetes and during transitional stages of life and care such as adolescent care and family planning. This in turn also improves confidence and capabilities of the diabetes communities to deliver effective support and increase self-efficacy. It is important for clinicians and healthcare professionals to champion lived experience representation in development and implementation of healthcare services. This includes pathways between clinical and community design care and support, as well as ensuring those with lived experience are remunerated. The NHMRC and Health Consumers New South Wales now have guidelines for this, as well as classifications of capability. Now, we've gone through a lot of resources and tools today, so I want to leave you with this vision and a closing challenge. This is as someone who over 30 years ago was told I may not be able to have a family, but with the right support, I was able to successfully manage my diabetes through pregnancy and have 2 children. The next time you see someone with diabetes, remember, they're not just managing a medical condition, they're running a complex 24/7 health enterprise. Your role isn't to manage them, it's to ensure they have the tools, respect and support to manage brilliantly. These are my references from what we have discussed today if you are wanting further information and more practical examples that you can implement in your care for people with diabetes. Thank you.
Thank you, Rachel. And joining us today is Rhonda Thompson, who will reflect on her experience on the challenges of diabetes management from a carer's point of view.
Talofa lava, Pacifica greetings, hello. My name is Rhonda Thompson and I am the lead community activator for the Western Sydney University Pacifica Preventing Diabetes program. Today I'm here to share my lived experience as a carer, supporting my husband as he lives with the complications of type 2 diabetes. My story is not just personal. It reflects the wider struggles of our Pacifica community here in Australia. That includes people of Pacific and Maori ancestry, with our largest groups being Samoan, Fijian, Tongan, Cook Islands and Maori. We are a community deeply connected by culture, faith and family, but we also face unique challenges when it comes to health. According to the 2021 census data, there are over 131,000 Pasifika people living in New South Wales, the highest concentration of families living across Western Sydney and southwestern Sydney. Diabetes is significantly more prevalent in Pasifika communities compared to the general population. For every one person from the general Australian population admitted to hospital with diabetes complications, there are 7 of our Pasifika people admitted. These admissions are often at late stages, leading to poorer outcomes and more complex care needs. In 2024, my husband became one of the 7 Pasifika admissions who entered hospital at chronic stage with a respiratory infection. By the 3rd day in hospital, he was now in heart failure. On the 10th day, he was moved to intensive care, critical with congestive heart failure, kidney failure, and compromised lungs. At this stage, doctors were now letting us know to prepare for the possibility of end of life. But after 6 months of hospital, we were truly blessed to come out on top, and he survived. There had been signs in the months before leading up to this, but they were confusing for us. We were travelling between extreme climates, juggling 12-hour shifts in between our travels. And I noticed a change. He was always tired, falling asleep easily, and his legs and feet were swelling. But instead of seeking help, he was self-diagnosing, blaming the symptoms on travel, work, and fatigue. This is the reality of many Pasifika families: late-stage admissions, confused symptoms, and a culture of pushing through until it's too late. One of my biggest challenges during this time was keeping up with the medical language. My husband's condition was deteriorating day by day. He was less tolerant, less patient with the doctors, assessments, and the endless questions. He'd often say to me, "You talk, because it's all too much." Eventually I took over. I had to detach emotionally from what was going on and stay connected with his medical team. It wasn't easy. It took time before the doctors saw me not just as a spouse, but as someone who truly knew my husband. And after 13 months of hospitals and recovery, we have a full healthcare team now. Other than the GP and cardiologist, we have a nephrologist, endocrinologist, and others that are in his care. Though to this day, he still won't go to a specialist appointment without me. He depends on me to speak, to question, and to understand. And as a carer, I'm relaying everything to him in simplified language. It's hard. I feel responsible for his quality of life, and I carry this fear that I might fail him one day. He still shuts down when the information gets too much. And this isn't just his story. It's a common experience across our Pasifika people. The language barrier in healthcare is real. Our Pasifika culture is rooted in generational traditions and large family dynamics. We live in the presence of 3rd, 4th, even 5th generations under one roof. In our homes, a good experience is shared well, and so is a bad one. We look at diabetes. It is a household word, but real knowledge, that's not always there. We know what heart attacks, kidney failure, and amputations all look like because we expect them as they are in our family history. We've lived through it. We've nursed and cared for generations of loved ones who have passed away from uncontrolled diabetes. This isn't just about individual choices. It's about the system around us. After migration, our lifestyles change. We face socio-economic pressures, genetic factors increasing our risk and barriers navigating health services. So let's take a moment to look at what diabetes means in our language. Medically, Diabetes is defined as a chronic metabolic disease. It's a condition where blood glucose levels are too high and the body does not produce enough insulin to regulate it. But when we translate the word diabetes into Pasifika languages, we get in Samoan, maisuka, meaning sickness caused by too much sugar in the blood. In Tongan, mahakisuka, sickness again caused by too much sugar in the blood. In Fijian, it's matenisuka, death by sugar, too much sugar in the blood. And our Cook Islands is totovene, which means sweet blood. And when you ask someone in our community what diabetes is, the most common answer is, it's when you eat too much sugar. Here's my personal observation. We may have cross-translations or interpretations. In our Pasifika languages, we understand sugar as sugar, the sweet foods that we eat. And we rarely associate insulin in conversation, which is vital to understanding how diabetes works. This gap in translation, is it leading to a gap in knowledge? My husband was diagnosed with diabetes in hospital right after his first heart attack 15 years ago. There were consultations at his bedside to explain diabetes. Looking back, the life-changing error was that at the time we were focused on his heart recovery. I didn't read the pamphlets. We missed the diabetes part for a few years. But let me highlight 4 key challenges we faced and that many Pasifika families continue to face. Number 1, the source of information. The way information is delivered matters. Pamphlets, bedside talks, unfortunately do not stick at times, and especially when families are in crises. Number 2, the language barriers. Medical language is dense and overwhelming for us as Pasifika. At the time, we didn't understand the terminology. And number 3, prescribed changes versus cultural realities and traditions. We were told to change diets, buy medications, attend appointments, but the financial burden was real. The cost of living pressures and our cultural commitments to family, church, and village, these all compete with health priorities, and the system doesn't know that. Number 4, navigating services. Sometimes it's the source of information that stops the start. If the first experience is confusing, families disengage. Our story isn't unique, and it is the lived reality of many of Pasifika families. When it's too overwhelming, we go back to what we know, our generational traditions. Faith and culture are woven into everything we also do. They're not just practices. They're affirmations of support for spiritual and emotional strength to carry us through the hardest times when accepting death by chronic disease. So we need to reach our Pasifika community. We need to capitalise on cultural community leadership. Pasifika communities are guided by strong cultural values and respected leaders. So by co-designing solutions with elders and leaders, we can build trust and ensure relevance with you. Number 2, strengthen consumer representation. Pasifika voices need to be present at our decision-making tables. Lived experiences matter. When consumers lead, systems become more responsive and effective. Number 3, invest in community-based education. Health education must be delivered where people gather, the churches, their community halls and their family homes. We need to be culturally grounded, language accessible, and led by familiar faces in the community. And finally, number 4, empower sustainable community-led models. Sustainability comes from ownership, not dependency. We need to empower the community and allow them to lead change that reflects our diversity. As a family, we are living the best we can with a new normal shaped by restrictions, limitations, and hope, all the while with the complications of diabetes. We're still learning through trial and error. Every day is a lesson and a reminder that my husband survived and we have to keep going. Thank you.
Thank you, Rhonda. Some excellent insights into real-world challenges and the importance of effective self-management. We'll now take a short break. Stay with us as we continue our conversation shortly. Welcome back to the last section of the symposium, where we'll discuss how non-pharmacological measures can support safe and appropriate use of medicines in people living with diabetes. First, Dr. Robin Barnes will explain how food can be used as medicine for diabetes management.
Hi, I'm Dr. Robin Barnes, Senior Diabetes Dietitian and Diabetes Coordinator for South West Sydney. Today, I'm going to be talking about how to optimise diet for people with diabetes. The focus of this presentation is on type 2 diabetes. Thank you so much for the invitation to present at the National Medicine Symposium. Is food medicine for people with diabetes? This slide highlights the potential reductions in HbA1c by medical nutrition therapy. That is, dietary advice provided by a dietitian versus a range of commonly used diabetes therapies. For context, this medical nutrition therapy relies on tailored counselling, structured plans, and behavioural support. As you can see, possible improvements can equal and even rival some potential therapeutic effects, especially in very engaged individuals. So, what sort of diet are we referring to? Well, the evidence shows that there isn't a one-size-fits-all approach, as a whole range of dietary patterns have been shown to improve glycemic control. The good news is that there are options for people, allowing for individualisation to personal and cultural preferences. But the bad news is it can be confusing for people with diabetes to know what to eat. However, we do know that not everyone needs to follow a low carbohydrate diet, as dietary patterns such as the Mediterranean diet, the DASH diet, and low GI diets have all been shown to improve glycemic control, and all of them contain carbohydrate, but of course healthy sources of carbohydrate. So what are healthy carbohydrates? Patients have often presented to me confused about what they should eat, as they have often been told to cut out the carbs, either by social media or by a health professional or both. And as a result, they've often cut out healthy as well as unhealthy sources. And there's a big difference, as we all know, between lentils and lollipops. But all carbohydrate-rich foods can often be grouped together and collectively labelled as bad. However, the evidence shows that both the amount and the type of carbohydrate impacts on blood glucose levels. Carbohydrate-rich sources that are high in fibre have a lot of health benefits, including lower blood glucose levels, satiety, and therefore lower weight, and also lower cholesterol and blood pressure. There are also other beneficial sources in carbohydrate-rich foods, such as calcium found in yogurt and cow's milk, which are very well absorbed and vital for bone strength. So people with diabetes should be encouraged to consume healthy sources of carbohydrates such as fruit, legumes, dairy, whole grains, but of course there needs to also be guidance on recommended serving sizes. Low carbohydrate diets have been shown to improve HbA1c as well. If an individual wants to follow one, there are some important considerations. They should be encouraged to include lean protein sources, healthy fats, plenty of non-starchy vegetables, and low carbohydrate fruit. Otherwise, there are risks of nutritional deficiencies, especially if followed long term. If the patients are on specific therapies that can cause hypoglycemia, such as sulfonylureas and/or insulin, these are likely to need to be reduced, often before starting the diet and as they lose weight. These sorts of diets are not recommended for all people with type 2 diabetes, and extremely low carbohydrate diets are definitely not recommended in pregnancy or for people with type 1 diabetes. For individuals who want to continue to eat healthy carbohydrate sources, there's plenty of evidence that the Mediterranean diet benefits glycemic control and also cardiovascular outcomes. And this diet is really a whole diet approach, which is high in healthy fats, particularly olive oil, fruit, vegetables, whole grains, and particularly is low in refined and ultra-processed foods. Changing an entire diet can be unrealistic for many. So if there's one group of foods to work on reducing, it's the ultra-processed foods. Some processing can have a minimal impact on health, such as the amount required to make whole grain breads and in the process of canning foods. But there's more and more evidence that ultra-processed foods are harmful to health. And a recent survey showed that up to 40% of the average Australian diet comes from ultra-processed foods. So a simple message should be, rather than cut the carbs, that patients should be encouraged to cut back on ultra-processed foods such as white bread, soft drink, lollies, cakes and biscuits, and to eat minimally processed foods, foods closest to their natural state as possible. The great news about dietary changes is they often achieve concurrent reductions in blood pressure and cholesterol even without weight loss. However, the reductions are greater the greater the amount of weight loss. What is often not fully appreciated about diabetes is that a typical person often has as little as 50% of their remaining beta cell function by the time they're diagnosed. So medical nutrition therapy needs to focus on the reducing insulin resistance. So in other words, trying to ensure that the remaining insulin is working as effectively as possible. So that means that dietary changes, including weight loss and nutrients known to improve insulin sensitivity, such as is the case with many healthy carbohydrate sources, is really what should be done in order to target not only the symptoms, in other words, hyperglycemia, but also the underlying cause, the insulin resistance. This graph is showing even more clearly the extent to which the improvements in HbA1c are possible depending on the amount of weight loss achieved. On average, the greater the weight loss, the greater the improvements in HbA1c. So what is the best diet for weight loss? Is a low carbohydrate diet the best diet? Well, a systematic review of 61 randomized controlled trials surprisingly found that there was little difference in weight loss achieved via a low carbohydrate diet versus a carbohydrate balanced diet. The key point is that in most of the randomized controlled trials looked at, the total energy intake was restricted to a similar extent in the intervention group to the control group. And so that is likely where the secret lies. Reducing the total amount of calories eaten is the only way to lose weight, and it's a matter of supporting the individual to find the right approach for them to achieve their calorie restriction required. Knowing that we don't have to be telling patients that they have to follow one type of diet frees up weight loss advice to focus on tailoring to the individual. The key areas of focus should be on cutting back on energy-dense foods, such as takeaway and ultra-processed foods, and addressing portion sizes and encouraging more fibre for fullness are all important messages. Too often, the most important variables are overlooked. How easy is the diet to follow in the longer term needs to be considered, as well as provision of long-term follow-up, not only during the weight loss stage, but during weight maintenance as well. Some people find approaches like intermittent fasting, for example, having a very low energy diet for 2 days a week, or time-restricted eating, limiting eating to a window of 6 to 10 hours, are helpful tools to help them to reduce their calories. However, medication adjustments are likely to be needed, especially if the patient are on medications such as sulfonylureas and/or insulin and are therefore at risk of hypoglycemia. Another important point is to provide realistic advice. This highly evidence-based guide to healthy eating is suitable for most Australians to follow, including people with diabetes. However, as little as 5% of Australians eat like this, and 96% of Australians don't eat enough fruit and vegetables. Be realistic with your advice. Encourage the patients to set 2 to 3 realistic goals that they think they can achieve at the moment in the context of competing priorities. This leads to the importance of tailored advice through an assessment and counselling process to ensure that the changes the patient has decided to make is suitable for them in terms of aligning with their culture and food preferences and budget, and medications need to be tailored in terms of timing in relation to meals. This tailoring highlights the importance of referring to a dietitian for this advice. It's really helpful if the advice provided by the dietitian is reinforced by the remainder of the clinicians supporting the patient's diabetes management to minimise confusion to the individual. Healthy eating can be perceived as expensive, especially for those from a low-income background. However, a recent study showing that 40% of the average Australian grocery bill is spent on ultra-processed foods, such as chips and chocolate. These foods can actually be more expensive per serve compared to items such as fruit and vegetables. One of the most helpful ways to eat healthily on a budget is to menu plan for the entire week. This saves on waste as well as impulse buying and the purchase of convenience meals, which are often more costly and usually more unhealthy. Freezing leftovers reduces waste and also reduces the consumption of these energy-dense foods. The key point is that we don't have to solve all the problems for the patients that come to us. You can provide evidence-based information and give individualised, realistic advice, but at the end of the day, at the end of the consult, it's best if the decisions come back to the patient. So I normally end my consultations by asking patients, based on our discussions today, what are 2 to 3 changes that you're ready to make to your diet? They know themselves and their situation better, and they need to own the plans to improve their health. In conclusion, no matter what additional therapies are used for the individual, nutrition therapy is the cornerstone. There are multiple eating patterns that can help improve glycemic control, with greater improvements seen with greater weight loss. There needs to be consistent messaging so that no matter what dietary pattern is followed, the patient should be encouraged to have whole foods, less refined foods, and less ultra-processed foods, and individualising is needed to address barriers to adherence and to ensure that the achievement in improved glycemic outcomes occur, as well as the weight loss and cardiovascular risk reductions. Here is a range of potential resources that you can use with patients, including the link to how to find a dietitian. Thank you so much for your time. I hope you found this information helpful. Enjoy the rest of the symposium.
Thank you, Robin. Now, Dr. Casey Peris will explore how exercise can play a key role in preventing and managing type 2 diabetes.
Hello, my name is Casey Peris and I'm a physiotherapist and academic at La Trobe University and the Royal Melbourne Hospital. And my research focuses on exercise and physical activity for chronic disease management. So how does exercise fit in the management of diabetes? As you've no doubt heard at the symposium today, diabetes is a major problem. Chronically elevated blood glucose levels damage blood vessels and nerves, leading to many problems. And the complications in diabetes primarily arise from two things: poor glycemic control and cardiovascular disease. And exercise is one of the few interventions that addresses both. Now, we can really overcomplicate exercise. So today my aim is to keep it simple. But first I need to clarify the difference between physical activity and exercise. Physical activity is the all-encompassing term for any movement above resting activity, such as cooking or gardening. Well, exercise is a subset of physical activity that is planned and purposeful. Now, all movement is good, but today I will be focusing on exercise as this is where the evidence is. And although I'll be focusing on type 2 diabetes, all the advice I give today is relevant for people with obesity or pre-diabetes, as they exist upon a continuum. And we shouldn't wait until someone has diabetes to intervene. Intervening early will help to prevent diabetes. So all the exercise advice I talk about is relevant across the continuum. So how does exercise work to manage diabetes? There's two main mechanisms. The first one is that it improves insulin sensitivity and lowers blood glucose levels to improve glycemic control. And the second is that it delivers systemic benefits across multiple organ systems to improve cardiovascular health. So thinking about the first mechanism now. When we exercise, insulin sensitivity increases. So this means that the muscles are better able to use any available insulin to use glucose both during and after exercise, which improves glycemic control and lowers blood glucose levels. Secondly, when muscles contract during activity, the cells can take up glucose and use it for energy, whether insulin is available or not, and this directly lowers circulating blood glucose levels. And this happens straight away, so this is a really powerful motivator for patients. They can literally see their blood glucose levels drop as they exercise. Now, this bottom pathway here lowers blood glucose levels for 3 to 6 hours. But because of the top pathway, a single bout of exercise improves glucose control for 48 hours or more, because the increased insulin sensitivity remains, which is how regular exercise then results in lowered glycosylated hemoglobin and improves the management of diabetes. Now, the most amazing thing about exercise is that it also has systemic effects to improve metabolic and cardiovascular health. Now, I won't go through everything here, and the reference is on the slide, but exercise improves muscle function and vascular health. It reduces systemic inflammation and acts across nearly every system that's affected by diabetes. So what's the evidence for effectiveness? It is strong. Large systematic reviews of randomised controlled trials show us that lifestyle interventions that aim for about 150 minutes of exercise per week reduce the risk of diabetes in adults by 45%, reduces the incidence of diabetes for people with pre-diabetes by 58%, and can reverse diabetes in people with type 2 diabetes in up to 60% of cases. Now, most importantly, exercise is effective even in the absence of weight loss. And that makes sense when we think back to the mechanisms that I described earlier. It acts on glucose control even without weight loss. Now, this is a graph from a large meta-regression analysis of 126 randomised controlled trials. And what you can see here is that glycosylated hemoglobin on the vertical axis reduces with increasing amounts of physical activity. So as you can see here, the more physical activity, the better, up until about 240 minutes per week of physical activity, that all-encompassing activity levels. But here's the key point. The biggest improvements are seen when someone goes from doing nothing to doing something. And that's a very powerful message for patients. There's not a certain threshold you have to meet to get the benefits. As soon as you move from doing nothing to doing something, you'll get improvements in glycemic control. So what types of exercise get you these benefits? Firstly, aerobic exercise. These are things like walking, cycling, jogging, swimming, or even arm cycling. To get the benefits without the injury, we aim for moderate intensity aerobic exercise. So that's puffing a little bit, but still able to maintain a comfortable conversation. The next type of exercise that we know is effective is resistance or strength training. So this includes lifting weights or using resistance bands, bodyweight exercises or machines. And it improves glucose control in similar ways to aerobic exercise and the mechanisms I described earlier, but it also increases muscle strength and muscle mass and improves muscle composition so that the muscles are more efficient at using glucose both during and after exercise. Again, we're aiming for moderate intensity here, which means that someone is able to do a certain exercise only 10 or 15 times before they fatigue. Now, because they act slightly differently, more and more research shows us that even though aerobic exercise is effective alone and resistance exercise is effective alone, together they're even more effective and they deliver the best results and the best improvements in glycosylated hemoglobin. So all of this research has led to exercise guidelines that recommend people complete 150 minutes a week of moderate intensity aerobic exercise, spread out over at least 3 different days of the week. So if we remember how exercise acts to improve insulin sensitivity, only for 48 hours or so, we want these exercise on non-consecutive days of the week and not all completed in one big bout on the weekend. So a good go-to is about 30 minutes on 5 days of the week. But this doesn't have to be all in one go and non-stop. This can be broken up into smaller bouts, so 10-minute bouts if needed, if someone's not able to complete 30 minutes all in one go. And it's still effective because the benefits start straight away with exercise. And it might even be more effective if these 10-minute bouts are completed after meals. The guidelines also recommend strength training on 2 to 3 days of the week on, again, non-consecutive days. So with strength training, a person would aim to do about 8 to 10 different exercises, 10 to 15 reps of each exercise, 1 to 3 times through. Now in the guidelines, and thinking about that graph from earlier, more exercise is better, but anything is better than nothing. So we recommend that people are as active as their conditions allow. So with these guidelines in mind, you should be really comfortable recommending these for all people with diabetes. But because of the ageing process and because of the exacerbation with diabetes and disuse, there is degeneration of muscles, ligaments, bones and joints in middle and older aged adults. So for these people, if they wanted to do more vigorous intensity activity, they should complete a comprehensive exercise assessment prior to this. But either way, it's important to remember that anything is better than nothing and low to moderate intensity exercise is safe. So get them to start slowly and progress gradually. Another important tip is that we really need to focus on sustainability. We don't want to be too rigid with the guidelines and we want people to think about what they can achieve. What do they enjoy? What can they fit into their everyday? Considering any comorbidities they have, because anything is better than nothing. So thinking about some of the common conditions present in diabetes that might affect the type of exercises people can do. The first one is peripheral artery disease. Exercise is still recommended, but modifications will need to be made to reduce discomfort. So here we just need to work within the limits of what's comfortable for the person. So doing frequent shorter bouts of aerobic exercise and interspersing that with upper limb training or strength training or aquatic exercise will help to do enough physical activity to get the benefits. For patients with proliferative diabetic retinopathy, strenuous activity may cause hemorrhage or detachment. So these individuals should avoid anaerobic exercise such as high intensity interval training, heavy weightlifting or sprints. And they should also be avoiding any physical activity that involves straining or jarring. But the moderate intensity activity that is recommended in guidelines is still absolutely fine. The next one is nephropathy. So patients with overt nephropathy often have a reduced capacity for physical activity, but there's no reason to limit low to moderate intensity exercise. Now, they should avoid high intensity exercise due to the impact on blood pressure, but if they really want to do vigorous activity, their blood pressure needs to be monitored closely. And the last one on the slide there is peripheral neuropathy. We need to be careful with weight-bearing exercise here, especially for people who are new to exercise, because repetitive exercise on insensitive feet can ultimately lead to ulceration. So if someone is new to exercise, they just need to ensure that their socks and footwear are good so that their feet stay dry and avoid blisters, and they must be taught to monitor closely for any damage to their feet, both before and after exercise. But again, starting small and progressing slowly here works really well. And using strength training or upper limb exercise to give the feet a break on alternate days works really well as well. So the main message here is that there is always a safe option, regardless of complications and comorbidity, for people to do exercise with diabetes. So what's our role here? The role of the healthcare professional is primarily education. One of the biggest barriers to using exercise in diabetes management is lack of appropriate education. So education needs to be consistent, it needs to be scaffolded, and it needs to be topped up over time. So it's important that we're all knowledgeable and provide consistent messaging to our patients. So a good way of doing this is thinking about the Making Every Contact Count framework. So every time that we have an encounter with someone with diabetes, we need to ask. We need to ask what they already know about exercise and what exercise they do. And we need to ask if they're happy to have a discussion and learn more about exercise. We need to advise. We need to give them education and advice about what exercise to do, how exercise works, and some options for them. And we need to refer. We need to refer on for specialised help with an exercise physiologist or a physiotherapist if needed. And remember, exercise can be as powerful as medicine, so we need to prescribe it like medicine. We start on a low dose and we build up as tolerated. So my take-home messages. It's important to include exercise as part of diabetes management for all patients. Adherence may be challenging and there may be comorbidities, but you need to give every patient the opportunity to try exercise, because even small changes make a difference. And if needed, refer on for support. Thank you.
Thank you, Casey. Mental health is often overlooked in the management of diabetes. Sarah Lamb will discuss how diabetes care can be optimised by addressing and supporting psychological health.
Hi, I'm Sarah Lamb. I'm the clinical psychologist at the Bankstown Hospital Diabetes Centre. Thanks for inviting me to speak at the National Medicine Symposium 2025. I'll be talking on mental health, which is the foundation of diabetes self-management. Good mental health is the foundation of diabetes management because diabetes management is self-management. To keep blood glucose in a healthy range, a person with diabetes must stay organised and manage multiple diabetes tasks, make complex decisions, predict changes or manage unpredicted changes, and do all this while juggling their normal lives. They need reasonable mental health to be able to do all this effectively. We've long known that mental health can be negatively affected when a person has diabetes. This can lead to compromised diabetes self-care, including compromised medication taking, and physical health then suffers. I'll outline these relationships and I'll also discuss steps that clinicians can take to address suboptimal mental health in people living with diabetes. This is important because mental health is often missed in a person's diabetes care. In general, there are two broad categories of distress that people experience when they have diabetes. The first one is diabetes distress, and this is distress that's directly related to having diabetes and to living with diabetes. The second category is mental health conditions. There are many psychiatric conditions that are linked with diabetes and occur more commonly when a person has diabetes than when a person doesn't have diabetes. These two categories, diabetes distress and mental health conditions, are separate categories, but there is overlap, and they can co-occur, so someone can have both diabetes distress and a psychiatric condition. They're both important because they're both associated with harm to physical health, and they must be addressed. Identifying accurately whether it's diabetes, distress, or a mental health condition is also important because the intervention that will be needed for treatment will be different. Diabetes distress, the first category, is extremely common. Estimates of prevalence vary depending on how it's measured, but generally it's thought to be up to 80 or even 90% of people have at least one source of diabetes distress that is clinically significant and impacts on their lives. This is understandable because diabetes has such high demands and the management is so complex. There are also many interpersonal issues that can occur with friends, family, colleagues, and clinicians. And people often have at the back of their minds a constant worry about the complications they may get in future. There's also the unpredictability of the condition to deal with, where doing the same thing on different days can lead to different outcomes. Not surprisingly, people often end up feeling overwhelmed, frustrated, guilty, or hopeless about their diabetes. This distress is often invisible to clinicians, and many studies have found that people with diabetes are rarely asked about their emotional well-being. Studies also consistently find that people want their clinicians to ask about their mental health, and they want their clinicians to provide them with psychological support. It makes a difference to them. This is important because diabetes distress is modifiable with the right professional support. But not only that, it's also thought that a big contributor to diabetes distress is when clinicians do not provide enough understanding and support to the person about the emotional aspects of diabetes. Diabetes distress is a normal reaction to the burden of having diabetes. It's considered to be a complication of diabetes rather than a separate comorbidity, and it's not considered pathological. Intervention for diabetes distress should occur within the diabetes setting and should be performed by regular diabetes clinicians. And all parties can work together to discover what might ease the burden of diabetes for the person with diabetes. This is in contrast to the second category of psychiatric conditions, which should be treated by mental health professionals, but ideally these treatments should be integrated with the person's treatment of diabetes. So the mental health conditions that have been linked to diabetes are things like mood disorders, eating disorders, stress disorders, so post-traumatic stress disorder, or people who've had some sort of complex trauma or adverse childhood events, severe mental illnesses, anxiety disorders, sleep-wake disorders, sexual disorders. These are all more likely to occur when someone has diabetes than when someone doesn't have diabetes. The prevalence depends on the disorder, but generally someone with diabetes is 2 or 3 times more likely to have a mental health condition than someone without diabetes. And the relationship is often bidirectional. So having a mental health condition can make diabetes more likely, especially type 2 diabetes. And having a mental health condition tends to complicate and worsen the outcomes of diabetes. For more information, a really good summary is provided in the Canada Diabetes Guidelines, the mental health chapter that was updated in 2023. Diabetes distress and mental health conditions have a lot of differences, but they have some important similarities. And the main one is that they both have very detrimental effects. So they both lower quality of life, they both reduce diabetes self-care ability, they both lead to a higher A1C, more diabetes complications, and higher mortality. The effect of emotional distress on medication-taking behaviours is starting to get more attention. Unsurprisingly, psychological distress predicts lower medication-taking rates, including initial uptake of medication maintenance and treatment intensification when needed. When investigated further, researchers have found that an important barrier to medication-taking behaviour is the beliefs that people hold about medication. A key recommendation to support medication taking is to directly address a person's concerns about their medication. The clinician must be receptive to concerns and form a collaborative treatment plan that is most likely to be carried out. This slide lists some examples of common concerns that can be a barrier to medication taking. The concerns include practical concerns like pain or cost, concerns of harm from the medication, fear about what the medication means symbolically to the person, so for example that they've failed or that it's proof that they're really ill now, and also interpersonal concerns such as the fear of discrimination by others. The first steps to addressing mental health can be included in routine consultations. So firstly, always ask about emotional distress. It's also important as a clinician to show that you really understand how hard it is to have diabetes and to give people the message that it's normal and common for them to be struggling because diabetes is a tricky condition to manage. For many people, just hearing this message and receiving empathy from their clinician can make a big difference in lowering distress and helping them feel relieved that what they're feeling is not abnormal. It's also really important for the clinician to build hope and help the person to understand that even small changes can make a big difference to their diabetes, so they can take things slowly and step by step and eventually get there. All treatment decisions should be collaborative and should consider the person's barriers to treatment. So patient-centered care is of the essence here. And when someone has high levels of emotional distress, they should be followed up in clinic more frequently than you normally would to keep track on how things are going. And they should be referred if things are not improving or if things are getting worse. In summary, good mental health is the foundation of good diabetes management. Unfortunately, many people with diabetes experience suboptimal mental health, which in turn affects their diabetes self-care. They have lower quality of life and poorer diabetes outcomes. When clinicians inquire about and recognize emotional distress, they can support the person towards better mental and physical health. Thanks for your time.
Thank you, Sarah. We've heard from David and Jennifer on how diabetes technologies such as insulin pumps and continuous glucose monitoring, CGM, and apps have enhanced the quality of life of people living with diabetes. Now our panellists will take the discussion further, exploring the benefits and ongoing challenges of using technology in diabetes care. Over to you, Lee.
Thank you, Andrew. Good afternoon, everyone. I'm Dr. Lee Fong, a medical advisor for the Commission and a general practitioner from the Hunter region. It's been striking to me how many of the speakers in this symposium, including Spiros, David, and Jennifer, have highlighted, firstly, how much diabetes technology like mobile apps, continuous glucose monitors, insulin pumps, and so on have evolved in the past few decades. Then how these technologies have helped people living with diabetes to better understand how their bodies respond to medications and food, how that understanding supports effective self-management of diabetes, and how enhanced self-management results in improved quality of life and better health outcomes. Frankly, it all sounds overwhelmingly positive. But what are some of the considerations when it comes to using these very exciting technologies? Well, it turns out that many of you have been thinking along these exact same lines. So thank you to everyone who has submitted questions on this subject. To help us work through some of those questions, I'm delighted to introduce our panel experts. On my left, Ms. Rachel Hicks is a PhD candidate and research assistant at Western Sydney University. Rachel has extensive lived experience with these technologies as they've evolved. Thank you for joining us, Rachel.
Thanks for having me.
On my right is Associate Professor Shane Hamblin, who's Head of Endocrinology and Diabetes at Western Health and brings with him almost 4 decades of endocrinology experience. So thank you for joining us, Shane.
Thanks very much, Lee.
Rachel, I might start with you. We've had a question about equity of access to these novel technologies. Can I ask you, what's your experience of getting access to technology like continuous glucose monitoring, insulin pumps, and how has that changed over time?
Very good question. So originally I was able to access an insulin pump thanks to my family having access to private health insurance. But in terms of a more hybrid closed loop or the combination with a continuous glucose monitor, I didn't get access to this extra component until much later on when I was pregnant with my firstborn. And it was at this time that the continuous glucose monitors had just become subsidised for use during pregnancy. So prior to that, cost was the main barrier to accessing this technology. But throughout the process of pregnancy, getting access to that made a world of difference. It really improved my self-efficacy with diabetes management during such a transitional stage of life. And then we saw the government then continue the subsidies even further from planning pregnancy and then extending the subsidy to those with type 1 diabetes outside of pregnancy with that reduced cost as well. So going into my second pregnancy, I had a full hybrid closed loop experience. And this in turn, it just seeing the data in real time and having the opportunity to collaborate with my team in real time with the data we were seeing really helped my experience. Though we are seeing that cost can still be a barrier because whilst we do have the subsidies for continuous glucose monitors, if you want a full hybrid closed loop experience, pumps are still quite unaffordable for most.
Can you give me a little bit of an idea about how much it costs? Like what is the out-of-pocket now?
For an insulin pump, we're still looking at thousands, sometimes tens of thousands, depending on the model that you're looking at. So it's definitely a huge barrier for most, especially in a cost of living crisis. And if we're looking at private health insurance, that can be several hundreds of dollars per month if you are someone that has a family. So it can be definitely out of range for most.
So in that context, so it sounds like there's definitely significant financial barriers. Are there other groups in the community who are missing out on these technologies?
Absolutely. So I think for quite a few of our vulnerable communities where health literacy and technological literacy is much lower, the ability to adapt to these technologies and access them, it's definitely not as readily available, or the uptake as well, because there may be quite a bit of overwhelm regarding the amount of knowledge and the amount of confidence that you need to handle this technology. And especially we're looking at our First Nations communities as well, where they may not even have access to baseline technologies. We're looking at access to keeping insulin in a fridge. Something like an insulin pump is definitely out of the picture there as well.
Yeah, okay, that's really interesting because I do some work with people experiencing homelessness, and exactly the same issue comes up in terms of storage of insulin, for example. So yeah, that's really interesting. So Shane, if we sort of focus on that issue for a bit for the next question, for people that are more vulnerable, who say, for example, might have cognitive impairment or disability, what supports would need to be in place in order for them to safely use continuous glucose monitoring and maybe even insulin pumps?
Right. I think CGM it's going to be safe. Insulin pump is another question. So if we just start with CGM, I think if somebody can put on the CGM or have someone put it on, unless it falls off, it'll be working, and then you just need, well, who's going to look at the data? And one of the key things is if the data is being accumulated and you don't do anything about it, it's a bit of a waste. So if someone's got a significant other or a carer, then that would be the solution there for CGM. For an insulin pump, I think this is going to be an increasing problem as people with type 1 diabetes are on this technology, and as they age, and there are increasingly people in their 70s, 80s and now 90s with type 1 diabetes. When they do develop cognitive impairment, what happens? So they go into aged care, and right now it's a little bit of a black hole. And I think that one of the key things is how do you manage in that situation someone who might have been very well controlled for a long time, and then they can no longer perhaps do everything themselves. So there are a few issues there.
Yeah, we might actually come back to the aged care one. So that's one of the questions that comes up later. We've got a scenario around that. But I'm sort of thinking, as you're just speaking then, if you have someone who's aging, who is using an insulin pump at home, the first sign that something's gone wrong might be something pretty bad. That's what it's sounding like to me.
Yeah, well, if they've got type 1 diabetes, it might be diabetic ketoacidosis.
Yes.
It could be severe hypoglycemia, you're right. Yeah. So I guess sometimes you've got to make the decision, is this technology still the right thing to be considering for that person?
Yeah.
Now, if they've got someone else who can help, that's wonderful.
Yeah.
So they might have a partner, they might have a son or a daughter who's going to be able to help, because you can actually remotely monitor. So CGM, you can set it up so the person can be the other side of the country and they can see what's happening to that person's blood glucose. Yeah. And then they can have an action plan. So this is happening all the time now with paediatrics. So in schools, parents can monitor, or other people can be monitoring what is happening to the blood glucose or the interstitial glucose. And then you can say, look, I don't know the way the glucose pattern's going. So that means you've got to have someone else who is prepared, is able, and is educated into doing it.
Okay, well that sounds like a great safeguard, and I wasn't aware of that, the ability of someone else to tie in and watch that data happening basically in real time.
Yeah, it's fabulous. I've had patients who've their lives have been transformed. The parents' lives have been transformed because they know the kid's all right at school.
Yeah.
They're not worrying about them.
Yeah. And equally, kids could be massively reassured that their parents are going okay.
Yeah, or when they're teenagers, massively not reassured. I mean, it depends on the stage of life.
Yeah.
But that's exactly, and so, when you look at that, we could adapt that for people with cognitive impairment or people who are developing the possibility that that's happening. And it's all going to be a lot of trade-off and discussion and sensitive discussions, because nobody likes to give over control.
Yeah.
And I think, Rachel, you've managed it for so many years, and then someone else tries to take over. It must not be fun.
Yes, exactly. And I think, there's quite a few things that come into play when we talk about technology. And there's also there's psychosocial aspects that we can think about as well, because technology is brilliant, but it can be quite overwhelming if you're not used to such technology. So we see a lot of people, when they are accessing this, need to have that reassurance and need to be able to have the support so they can get that self-efficacy to be able to continue with the technology. And then in terms of monitoring, we have things like, there's a lot of alarms that can happen with this technology. So overnight you could have alerts going off and alarms, and people can get alarm fatigue with this technology. So making sure that we have the options of choice, so that if someone is getting overwhelmed, we can look at alternative options. And if someone doesn't feel like they're able to make their diabetes management their own, looking at alternatives, because you might be more comfortable with manual injections and with a different type of CGM rather than closed loop with an insulin pump. I think it's all up to empowering individuals to have the choice of what works best for them.
Okay, so it's patient first. Exactly. So it's very much a patient-centric approach to this, as it always should be. Let's say there's a scenario where you've got a patient in a residential aged care, and you got a call at 2 a.m. And the call you get at 2 a.m. from residential aged care is that there's a patient who's on continuous glucose monitoring, and they've got an insulin pump, and it's just, the alarm's just going off. It's going off, it's going off. How could or should a GP respond in that situation? I guess part of that sort of wrapped up in what should be in place in the aged care facility to have safe management of these sorts of technologies?
Yeah, I think that's a great question. Look, you could put the same question. What happens if it's in a surgical ward in a big hospital in the middle of the night, 2 a.m.?
Yep.
The knowledge about what to do is really tricky. So that in a big hospital, it's fine if it's business hours. You've got the diabetes nurse educators around. But at midnight or what have you, I do get calls because I'm on call for a major hospital in Melbourne. And usually what we do is say, oh, this is no good. Disconnect the technology and we'll give them a dose of NovoRapid or some quick-acting insulin. I think in a nursing home, increasingly this is going to become an issue. So I think you have to have an action plan. I think you've got to think ahead and you've got to say, this will happen. You are going to get something going wrong. I mean, we know Bluetooth drops out all the time. We know ourselves, something happens at home with the internet. So I think you need to have an action plan. What do you do if this scenario occurs? Who do you call? Now, if it's a GP being called, I can tell you most times the response is it'll be a locum GP often.
Yes.
And it's call an ambulance, send them into hospital. And that's a shame. But I think for that sort of thing is I don't want to know as well, what's the blood glucose now? Have you done a finger prick? Just forget about the CGM. What's the finger prick? And have you done ketones? And I can tell you getting ketone results makes a world of difference as to how I respond. But they might not be able to check for ketones in the nursing home. So therefore you should plan, if you're looking after people with type 1 in a nursing home or anywhere, you need to have the ability to check for ketones. And then most of the time, I think in the middle of the night, 2 a.m, I would be disconnecting the technology. And we'd be saying, okay, they need some quick-acting insulin. And my kids used to say at mealtime, give them 6 units, Dad. So I'd get rung from the hospital. And, when they were 6, 7, 8, they'd learnt that 6 units sort of carried you through for a little while. So I'd give them 6 or 8 units of NovoRapid. Subcut. There you are. And then you've got to work it out because over the next few hours, you need to reevaluate. You need to see what's happening and you'd be checking the blood glucose again. But I think trying to have an action plan and work out what is going to happen. And the same if they're going too low. An alarm about being too low, what do you do?
Okay.
It's not easy. And for a GP, it's going to be very, very difficult. For an endocrinologist, it's hard. So I think for the average GP in a nursing home, when they're looking after quite a lot of people, it's going to be quite tricky.
Okay. So it sounds like work to be done.
Work to be done.
Work to be done in terms of planning for how this sort of technology can be safely implemented in a variety and probably an increasingly wider number of environments. Rachel, can I come back to you? So I think you've had an experience where you've turned up at a hospital and you've had a pump. Can you tell us a bit about that?
So yes, I think this comes down to education and hindsight, but there was a time where I was hospitalised for DKA, and at the time the hospital I was at was quite regional and weren't very familiar with diabetes technology at the time. So I was instructed to go off the pump and onto insulin there that they were going to manage themselves. And I guess at the end of the day, I advocate for myself by setting myself back up on my insulin pump, because at that time my management was much better if I was just handling things myself, because I guess there was kind of the attitude I was receiving from the treating team at the time is, we're not familiar with this technology, therefore we're going to ask you to not use it. But then when I was able to demonstrate, well, actually, this is what I can do, look how my levels have improved since I've put this back on. So I think what this is demonstrating is there needs to be really thorough educational resources that we can use across the board when we're looking at more people with diabetes being on wards that have insulin pumps, and we're looking at aged care facilities. We need to have effective educational resources so that not only do we have the ability for people to have confidence to go into hospital with diabetes with their technology, but also that we have these plans for when the technology decides to not work. So we're looking at effective pump management plans. This is where continuity of care is so important, and being able to connect with diabetes training teams to make sure everyone's got the resources for when technology decides to not work, which does happen.
Excellent. So it's a dilemma again. It's when, I guess, something new is happening and how can the system adapt to that? So Shane, Is this a common situation where people turn up to an ED, they've got a pump, and especially if we push into the after hours, that whole question about who does the person in the ED or who does the admitting registrar speak to in order to make a decision about what do I do with this thing?
Yeah, it's happening increasingly, and it will happen even more because the technology is so good. So the first thing to do is talk to the person. If the person's come into ED, why are they there? Are they delirious? In which case, okay, you're going to have to make decisions. But if they've come in with a broken leg, or if they've come in with something else but their brain's fine, the best thing to do is let them continue to handle the technology. However, in our hospital, in most hospitals now, there is going to be an endocrinologist somewhere around, or a general physician with an interest in diabetes, who will be fairly skilled in handling the technology. So if the person has got the ability to handle the technology because you just have a chat to them and they know way more than I do, okay, let them do it. Because as you said, Rachel, their control will be much better when they do that. But when the person they can't manage, they've got a delirium, they might have sepsis, then that's when you might have to take the technology out of the equation, and you might have to use intravenous insulin, or in some centres, subcutaneous insulin, basal bolus insulin, until the person's recovering. And then get them back on the pump as soon as you can. That would be the approach I'd take. If you're in a regional or rural place, usually you phone a friend. And our registrars all rotate to Wodonga, to Mildura in Victoria, and they've got a home hospital, and they'll often ring the endocrine registrar and get advice, and we're happy to help. In a smaller place where you might not have the backup, you might just have to say, look, this person, I don't know that they're with it enough. I might have to just put them back on subcutaneous insulin or intravenous insulin if the hospital supports that. You phone a friend, I think the biggest mistake that we used to make was when people came into hospital, we'd take the technology off them. Because we didn't know enough about it.
Yes.
And even now we get reports from patients that say everybody in ED came around and said, oh, what's this? Show me that, because they didn't know what it was. It's becoming more passé now, but still, there are times when patients are disadvantaged because we don't listen to them.
Okay. So again, things for the system to adapt to.
Yep.
Absolutely.
Yep.
Rachel, can I ask you a question now? We were talking earlier and you mentioned that you've also had another experience, which is when you've been to an airport, and that's been interesting in terms of what happens with security and an insulin pump. Can you tell us a bit about that?
Yes, so with technology, there are some challenges if we look at application in everyday scenarios. So something that's been quite discussed in detail in the diabetes community is airport security, because we're finding there's no consensus from the diabetes technology companies as to processes of what to do with your diabetes technology when going through screening. And then there's no consensus with airport security either. You can be flying in from Melbourne to Sydney and the processes are entirely different. So there's quite a bit of work to be done, and there are some organisations such as Diabetes Australia who are doing advocacy to improve education through airport security, and also prepare individuals so they are empowered to feel confident to go through the airport and not feel like this is an additional burden on them with that technology. But yeah, it's having that preparation and the resources to hopefully not be met with attitudes or stigma regarding the technology they have, and making the process as streamlined as possible. That being said, I think when I travelled, I think one of the most challenging situations I had, it was just a lack of awareness and a lack of knowledge on the technology, and it was a very regional airport in Australia that did not know the process, and I was confident enough to step up and say, look, this is essential for me, for my health. I cannot have this go through any of the machinery. I'm happy to have a pat down or any alternatives. But it's to make sure that people have the confidence to approach these scenarios, and just that broader awareness of diabetes technology in these public spaces with things like security.
So at the end of the day, an insulin pump should or could or shouldn't be going through an X-ray machine.
It depends on the model and it depends on the device. Some, generally as a rule of thumb, X-rays are off limits. Anything that could potentially cause the technology to have a failure. And I mean, the amount of funds that we are trying to maintain these devices, it's not a risk that we're wanting to take as well. So generally, as a rule of thumb, any of the components where the device could be exposed to anything that could cause it to fail is generally off limits.
So it sounds to me like avoiding potential catastrophe is generally a good idea.
I mean, I kind of go to the airport prepared, look, I'm probably going to have extra time at security, I might have to have a pat down, and I think having that preparation in advance, I'd rather that than having an insulin pump fail while I'm on the way somewhere else and then having to switch to technology that I'm not as familiar with.
Absolutely. Shane, I think you mentioned you had a colleague who...
Yeah, well, the manager of diabetes education where the hospital I work, she basically just says, look, this is keeping me alive and you are not going to separate me from my life-saving device. But she's got a lot of confidence. I have patients who don't want the world to know they've got type 1 diabetes. And so, you know, to actually say, I've got diabetes in the public place, pat me down, is quite stressful for them. I always encourage people to carry a letter from their doctor to say that they've got type 1 diabetes and they're travelling with insulin and so on. But I think it's a thing that is still a work in progress.
Okay, well, great points, including I guess having the confidence really to say, I'm prepared to have an alternative form of screening. Maybe even the confidence to say, hey, I don't want this out in the open. Take me to a private place for that to happen. And having a letter from your doctor. So yeah, some great tips. Thanks for that.
Thank you.
So that brings us to the end of this panel discussion. Thank you again so much to everybody who submitted questions to this. Thank you to Rachel. Thank you to Shane for sharing your very helpful insights. So been fascinating questions. I'm very much looking to the future. Back to you, Andrew.
Thank you all. I would like to welcome Professor Christine Kilpatrick, AO, Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, for the closing address.
As Chair of the Australian Commission on Safety and Quality in Healthcare, I'd like to sincerely thank everyone for joining us today. It has been a remarkable day of learning, reflection and collaboration. This symposium has brought together thousands of people from across Australia to explore one of Australia's most pressing health challenges, the safe and quality use of diabetes medicines. As we've heard today, diabetes affects more than 1.3 million people in Australia. The complexity of this disease means that managing diabetes is about far more than controlling blood sugar levels. It's about delivering safe, effective and person-centred care. Our discussions have spanned everything from new models of care to the essential roles of nutrition, exercise and mental health. We've heard how new technologies such as insulin pumps and apps offer great hope for the future of diabetes management, but only if equitable access is prioritised. The most powerful message today is clear. Appropriate diabetes management goes beyond prescribing medicines. It's about giving people with diabetes the confidence, knowledge and tools to manage their own condition in ways that suit them best. I'd like to personally thank all the speakers, the organisers and everyone who has contributed to making this symposium such a success. Most of all, I'd like to thank our consumers, Renza, Rachel and Rhonda, who spoke so eloquently about the realities of living with diabetes. If you missed any of the sessions, please visit the Commission's website to access recordings and further resources. I hope everyone leaves this symposium more aware of the issues around quality use of diabetes medicines and armed with the actions and strategies that you can incorporate into your own work. By working together and listening to the voices of people with diabetes, I think we have a real opportunity here to improve care for everyone now and into the future. Thank you.
Thanks so much, Christine, and a big thank you to all the speakers today and to everyone who joined us for taking the time to listen, learn, and be part of the conversation. Thanks also to everyone who submitted questions. We got to as many as we could. Keep an eye out on your email and on the Commission website, where we'll be sharing more information in the coming days and weeks. Please continue the conversation around quality use of medicines in people with diabetes to ensure people receive safe and appropriate care. Have a great afternoon. Bye.